recording now. Okay, Assalamu alaikum everyone, and welcome to this educational session from Association of Pakistani Cardiologists UK. This is the first time we're doing it once we've got this organization name. So Jamal Khan is a consultant cardiologist at University Hospital Coventry in Warwickshire, who's very kindly agreed to give this hopefully a very elaborate and interesting session on cardiac imaging. So over to you, Jamal, and Ehsan will be the host for this session, and if Ahmed joins in, he can be the moderator. Over to you.
Okay. Yeah, thanks for the introduction. Assalamu alaikum to everyone. I just want to check, can people hear me clearly?
Yes, we can.
Yep, that's great. And I just wanted to check that my video was turned off and that you can just see my slide set. So with regards to questions, I just wanted to ask the main hosts, would you prefer question? I'm happy to have questions come in at the end or as I speak, sort of if you want to ask me questions relevant to the topic I'm talking about or at the end, I really don't mind. Is there anything that you guys prefer in terms of the format, or so I can go along with that?
Jamal, I think whatever you prefer, being the only speaker today,
Okay.
if you want to do it at the end, we can request them, but to keep it interactive, maybe every half an hour, pause for 2, 3, 5 minutes, maybe, and then see if any burning questions for that half an hour. Is that okay?
Yeah, that's fine with me. That sounds perfect.
Or if somebody, Raheel or someone, can keep an eye on the chat box with the questions,
yeah.
and then bring them
No
up.
problem, I will, yeah.
Okay,
That's perfect. So if you can update me on the chat box, I'm happy to answer questions as we go along, but I'll time myself as well from now, and every 30 minutes I'll stop for a few minutes, for 5 minutes, just for people to have a break if they want. So yeah, I'm going to talk this evening about multimodality cardiac imaging. It's a 2-hour session. I'm going to try to do the talk in an hour and a half, and I'm going to try and cover all the main modalities of cardiac imaging. It's a lot to cover in 90 minutes. So it's going to be a broad brush overview. And I imagine there's a wide range of seniorities of people in this group, ranging from registrars who may be junior registrars up to quite senior consultants. So I'll try to pitch it at a level that's suitable for everyone, but assuming that people may be completely new to cardiac imaging. So I'll start off basic and then I'll work my way up. But it is a broad brush overview, so it's really to provide you an insight. So we will move quite quickly through the modalities, but yeah, please ask me any questions that you want. So I'm going to try to cover the modalities that you'll be aware of, but also the intricacies and the new developments and contemporary aspects of each. And to give you an insight into how that modality works, the theory behind it, and then moving on to the practical aspects, and then also about interpreting them. Because no matter whether you do cardiac imaging or not, as a subspecialty, it's really important for you to know what's at your disposal, and there's probably a lot more at your disposal these days than you know about, and you've got this available at your fingertips. And then equally, cardiac imaging is one of those areas of cardiology that, again, even if you don't do imaging as a subspecialty, you'll be interpreting these scans yourself. You'll be looking at the reports and then basing your management on that. So it's important for you to understand the reports in a little bit more detail, and hopefully this will explain some of the things that you see or may not be used to seeing, and hopefully make cardiac imaging a more powerful resource for you, but also make the reports more interpretable and useful to you. So imaging can be non-invasive or invasive, and I'm going to focus on non-invasive imaging today. And it can be anatomical, functional, or both. So anatomical will be your modalities where you're really looking at 2D images or moving images, whereas functional aspects are looking at physiological processes such as ischemia as a process or mechanisms and function of blood flow across a valve. Some modalities or subsets of modalities can do either anatomical or functional imaging, but some of them can do both, and that really takes imaging to another level and really increases the value of that modality. So really, I think as a non-invasive cardiac imager myself, I'm a multimodality imager. I do echo in all of its forms, MRI and CT again in all of their cardiac forms, and I'm a real advocate of non-invasive cardiac imaging. I think it obviously will be very biased in my opinion on this, but I really do think it's the future, and the future is here now. It's constantly expanding, it's becoming more and more sophisticated. tests are becoming more accurate, and importantly, they're affecting management. They're having prognostic implications on patients. And there is a lot at your fingertips now that is really powerful. And I think, no matter what sort of hospital you work in, you may have a varying degree of complexity of imaging at your fingertips, but there's a lot no matter what type of hospital you work at. We'll talk about that today. So I'll do modality by modality, and the big chunk of this talk is going to be echo, mainly because that's the one you'll have most exposure to. That's the one that you'll be exposed to regardless of how senior you are, whether you're a junior SPR or a consultant. And I'm going to put the bulk of the talk, the biggest section of the talk will be on echocardiography because it's just so much more commonly used. And for all of these modalities, I'm going to start off really basic. I apologize in advance if it's too basic for some people, but it's good to start that way, especially, I think my main audience today is all of you, but with a real focus and emphasis on the trainees. I think it's important for you guys to have a good background of imaging, and that's why we'll start at a basic level. So hopefully it'll be applicable for everyone. So echo, really the theory of echo is it's simple. It's ultrasound waves that are projected from a probe, which is like a microphone coming from the echo machine. They go into the patient and they hit structures in the patient and they bounce back to the probe. So the probe is was a generator of ultrasound, but also a receiver as well. So it gives out ultrasound, it hits structures in the body and comes back to the probe. And depending on what the structure is made up of and how far away it is from the probe, you'll get a different appearance on the grayscale and intensity, and that will build up an image in 2D. And that will give you your image on the screen. You can look at structure, you can look at function, you can look at physiology and ischemia with echocardiography. It's very, very powerful. And I'll talk about each of the main 4 types, which I think you'll all probably be familiar with these. And then I'll also talk about 2D and 3D echo. 3D echo is a real sort of particular interest of mine and something I've been doing for a number of years, and I'm always trying to promote. And we'll talk about that later on. It may be something that some of you are familiar with and others may not be at the moment. So main indications for echocardiography. I think the main big ones are looking at the ventricles, both the anatomy and function. And function, when I say function, both systolic and diastolic function. Valvular assessment is the second big indication. Again, the structure and function of the valves. And then you've got the other indications, which are the sort of, I wouldn't say minor indications, but the big ones are really the ventricles and the valves. But you can see how robust and versatile echo is. It's excellent for all structures inside the heart and also some of the structures around the heart as well. So these are all things I'm sure that you're all familiar with. So the first type of echo is transthoracic echo. This is the workhorse of echo that we've all done ourselves by hand, no matter what specialty of echo cardiology you work in. And it's very safe, it's cheap. An echo costs about £40 to £50 to do. And the beauty of it really is you can do this at the bedside now as well. And the bedside echo machines are really just as powerful as the main departmental machines. The only things that the bedside echo machines won't have is usually 3D capability, but on a portable machine such as a CX50, which is the portable version of the main big Philips Echo, you can do pretty much everything you can do on a main system except 3D. I think I'm getting a message from 1 or 2 people asking them to be allowed into the room. Would the moderators or the host be able to do that? I've just had a couple of WhatsApps coming.
Hassan, can you do this?
Sorry, I've just done them.
Yeah, no problem. There was just a couple of people, I think.
Yep, they're all admitted now.
Okay, that's great. I'll just carry on from where I was. Those that have just joined, you haven't really missed much. I'm going to talk through each of the modalities that are available at your disposal these days and really give you an insight into the contemporary features of them and what you have at your fingertips. So we're starting off with transthoracic echo. So it's very accessible, it's very cheap, and it is extremely powerful, even at the bedside. For the trainees in the room, I imagine you're all doing your BSc logbooks at the moment and are well used to using the portable and the main departmental machines. I think one tip I'll give you with regards to training is BSc accreditation is really important. It's getting harder to get cases in the COVID era because elective lists are often cancelled and trainees do panic. What I would say is there's no need to panic when collecting your logbooks. There is enough time. Just be savvy and be smart about things and make the most of your on-call echoes. When you're on call, every echo that you're asked to do it in full. It takes 10 minutes longer to do it in full, and that means that you report it in full and you get a logbook case for your BSc. And that way you'll clock up 100 echoes just on call each year. And that's something I always promote to my trainees. You can really easily get numbers if you just play the game a bit and just be savvy about things. So make the most of your on-call echoes. They all count for the logbook. So with regards to transthoracic echo, you'll all be familiar with the views, or what we call the windows. So there's 4 main types. You have the paras. Can you see the mouse arrow, guys? Can you see my mouse moving?
Yes, we can.
Oh, that's great, thanks. So you've got your parasternal views, which you'll all be familiar with, your parasternal long axis, your short axis, and this is the difference between a 2D and 3D. So your 2D image looks like this, and this is the difference in quality that you get with 3D imaging, which I'll talk to you about in more detail later. Then your apical images, you'll be familiar. You have your 4-chamber, your 3-chamber, and your 2-chamber. And then subcostally, you've got your views here looking at the heart, which is good for looking at the intraatrial septum and pericardial effusions. And then you've got your IVC and hepatic vein that can also be assessed. And then finally, at the suprasternal notch, this is good for the aortic arch, great vessels, and for looking for coarctation. So this will be stuff I imagine everyone's familiar with, but just going through things basically for the trainees. And this is a normal echo. Just for those who are again training, just to get familiar with what normal looks like first of all. So this is a heart that is normal. The ventricles are of normal size. Systolic function is good. The valves are opening and closing well. You've got good radial function and you've got good longitudinal function. So this is a normal heart. And when describing systolic function, normal systolic function is where you have normal radial and longitudinal systolic function, and all the segments are moving well, and the ejection fraction is 55. That is what is classed as normal systolic function. I often get the situation where my trainees are doing echoes and they will find a heart that's got wall motion abnormalities, but the ejection fraction is normal. That is not normal systolic function. If you have any dysfunctional segments, that ventricle is impaired regardless of ejection fraction. Ejection fraction is not the definition of systolic function being normal. So I look at systolic function being of 3 types. It can be normal, where radial and longitudinal is normal. All 16 segments are contracting properly. And the ejection fraction is more than 55. Then you can have the situation where your radial function is good, systolic ejection fraction is normal, but your longitudinal function is impaired, your MAPC or your lateral TDIs. Again, that is not normal systolic function. That is a situation of normal radial function, but impaired longitudinal function and normal ejection fraction. And then the final sort of permutation is where you have normal ejection fraction, but regional wall motion abnormalities. So a couple of hypokinetic or even akinetic segments, but everything else is normokinetic, and the ejection fraction is normal. The way I describe that, I think the correct way is that you would say there is mild systolic dysfunction due to the presence of wall motion abnormalities in whichever segments you name them, but ejection fraction is normal. And that is not the same as normal ejection fraction. And it's a little bit pedantic, but the semantics are important really here. So they're my ways of describing what you could class as normal systolic function. And these are really the subtleties that are sometimes not appreciated. Even in the parasternal long axis view, people make the assumption that you have A2 and P2 on the mitral valve, for example. That's not always the case. This can be used to your advantage and disadvantage. If you don't appreciate the subtleties, you may misinterpret scallops, but if you appreciate them, then you have a lot more power at your disposal just from your single parasternal long axis image, for example. So your standard image will be this sort of Platts view, and which is usually A2, P2, but just a small movement up of the hand will open up the aortic valve further and then change it to A1, P1. And then a slight tilt down of the hand will close off the aortic valve. And when the aortic valve is closed, then you're definitely not at A1 and A2, and then you're at A3 and P3. So just subtle movements of the hands can open up all 6 scallops. So this is something that you can use at your disposal, but equally you've got to be cautious. Don't make assumptions that you're always at A2, P2. So there are subtleties even within the windows, just with small movements of the hands. So these are the main indications for TTE. So I'll just have this as an interactive thing where people can sort of shout out, or the trainees can say what is going on. So these are the main sort of key indications for transthoracic echo. So what's going on here, guys, for the trainees? What do you think this is showing? It's not a moving image, but what can you see here? Anyone want to come off mute and say?
Severely dilated left atrium.
Okay, and what do you think about the mitral valve?
This looks prolapse.
Yep, so there's prolapse here, yep, and you've got very eccentric, anteriorly directed mitral rigor. So yep, this is prolapse. So this is valve disease, and structure of valves is an important indication. And it's important to know the difference between prolapse and flail. You have 3 combinations of things in a valve that is floppy. The first one is where the closure, where the coaptation is normal, but the leaflets are bowing. The correct word for that is billowing. With that, you won't really get much MR because the coaptation is still correct. Then you'll have this situation where the coaptation point is below the annular line. That's prolapse. So that's where your leaflet is bowing and it's closing below the line. And then you'll have the worst case scenario, which is flail. And in flail, the leaflet will actually point the opposite way. And flail in 99% of cases will always be severe MR. So yep, this is prolapse. So this is on your Carpentier type 2 phenomenon, excessive mobility. What do you think here, guys? Again, for the trainees, anyone want to shout out? I apologize, it's not a moving image. What can you see here?
RV overload.
Yep, so these are linked together. So you've got septal flattening, and you can see where the cursor is. So this is taken in systole. So this is systolic septal flattening, and you can see RVH. So this is pulmonary hypertension. This is pressure overload. So pressure overload is systolic flattening all throughout the cycle, whereas volume overload is flattening in diastole. And you can see here very elevated pulmonary pressures. So pulmonary hypertension assessment, right ventricular assessment. And what can you see here, guys? What's the pathology here? Okay, anyone shout that out? It's quite obvious. It's
Aortic stenosis and MAC.
So this is severe aortic stenosis, and yeah, you've got MAC, and you've got that MAC extending into the posterior mitral valve leaflet. So you've got a fixed posterior leaflet as well. Good. So it's good for valve regurgitation, morphology, valve stenosis. Good for pulmonary hypertension of the right heart. What do we have here? What would you say this condition is here? Looking at the left ventricle.
Dilated.
Yeah. So this is dilated cardiomyopathy. You've got spherical and globally dilated and globally impaired ventricle. So this is your globally impaired ventricle, as opposed to what would you say about this ventricle here? You've got global impairment, and what would you say here for the trainees?
Septal bounce.
This discordant septum. What would you say about the type of dysfunction? Is it global or is it more regional?
This looks like balloon shape.
The ventricle is slightly rounded, but the main thing here is you've got your regional wall motion abnormality. So this is an akinetic lateral wall. So you've got global impairment, more with cardiomyopathies, and you've got regional impairment, which is usually coronary artery disease. So it's very good for looking at ventricular function and size, global versus regional, looking at the etiology of ventricular dysfunction. And what about this one, guys? What do you think is going on here on these leaflets?
Mitral myxoma.
So this is the mitral valve. This is endocarditis. This is nasty vegetations on the valve. So you've got severe regurgitation here. So it's very good for looking at endocarditis, looking at infections on the valve. This is the TOE. And then what do we have here, guys?
ASD.
Yeah, so it's an ASD. It's quite a big secundum. So it's good for congenital heart disease. And finally, what do we have here?
It's a cardiac tamponade.
So this is tamponade. So it's very good for looking at the pericardium. And finally, what do we have here? What's this?
Amyloidosis.
It could be amyloidosis, but
Hypertrophic cardiomyopathy.
yeah, so this is HOCM. So you can see transthoracic echo has lots of indications, and it's very, very powerful. So this is an example of HOCM with severe asymmetrical hypertrophy, and you've got SAM here. So they're the sort of main indications for transthoracic echo. LV function is more than just squeezing of the heart. It's systolic and diastolic. So systolic function, you'll all be familiar with Simpson's, which is a method of calculating discs, and it makes assumptions. It's accurate. It's the currently most commonly used method on echo. It's not the gold standard on echo. 3D is the gold standard. 3D more accurately approximates CMR, which is the gold standard of all the modalities. This makes assumptions because it assumes a cone-shaped ventricle. So you've got systolic function. And the BSE guidelines have changed now. They don't describe mild, moderate, and severe. They describe it as normal, borderline normal, or impaired. And then less than 35 is severe. So that's something you'll see. You'll stop seeing mild and moderate in your reports. And I think I don't disagree with that, because at the end of the day, when it comes to systolic function, the main things you're interested on is there systolic function and is there severe? Because severe is when you're going to think about Entresto in your devices. So I can see the logic behind this. So there's a slight change here, and just in semantics, but does it make a difference to what you do? Not really. It doesn't really make a difference to how you'll manage the patients. It's just a more semantics difference you'll see in the BSE guidelines that came out in March 2020. And then with diastolic function, again, which is HFpEF, these are the main markers. So this I always find quite useful. So with diastolic dysfunction, you really don't want to overlabel people with diastolic dysfunction. Think about the age of the patient, because E2A reversal is pretty much normal in elderly patients. So you don't want to be labeling everyone with having diastolic dysfunction just because of a big left atrium, a bit of LVH, or E2A reversal. So I like the fact that they're making it more robust and more specific now for diastolic dysfunction. So these are the main sort of markers of diastolic dysfunction: your average E over E prime of 14, reduced E-wave velocities on your TDIs, elevated TR to suggest a degree of pulmonary hypertension, and LA volume index. And this is the key. Please use indexed volumes. When you do echoes, I'm quite pedantic, as some of the imaging colleagues on this talk will be with the way we do things. Please index every single echo to BSA. Everything has to be indexed to BSA, or now for aortic dimensions, we're indexing them to height in meters, but everything has to be indexed. And if things are not indexed, there is no excuse for that. It takes 30 seconds to check a patient's height and weight, and it makes a massive difference to your interpretation of things. So please index everything. So if you have two, or if you have more than two, so three, if you have 3 or 4 of these components, then there is definitely diastolic dysfunction. If you've only got 2, then you need to look at the bigger picture, look at the patient's clinical features, look at the BNP, and then make your decision. But one, having one of these is not specific enough. So I like the fact that it's becoming more specific, because there is an over-labeling of people with diastolic dysfunction. So sort of practical questions I often say to the juniors really is, echo services are under a lot of strain. There's a chronic shortage of CPs in this country, and every centre pretty much will have a lack of CPs, which means waiting lists are long, CPs are under pressure. So you really need to be judicious with your echo requests. And we do vet them, and we will bounce them if they're not going to make a difference to the patient. And I think the question really always has to be, how is this echo going to affect management? If we know this patient's got severe valve disease 3 years ago, we're not going to do anything about it. Stop investigating it. Your patients who are too frail for a TAVI, just send them away. They don't need to have any echo ever again, because everything's going to be symptom-based. It doesn't matter what the LV is like in 3 years' time. So be judicious. If you're not going to make any intervention to that patient, I always ask myself, why even bother doing any further echoes on that patient? Because everything's going to be symptom-based. So only request echoes if they're going to affect management, and please be very judicious about that. And then, does an echo need doing as an inpatient? Not every echo does. Very rarely does an echo need doing as an inpatient. And I think the COVID status is critically important now for inpatients. And I'll show you on the next slide some guidelines I've written for my hospital. So for inpatient echoes, you really absolutely have to provide the echo department with a COVID status, because that makes a huge difference to the safety of doing that echo for the person doing it. And really, this is another one. When you request stress echoes or echoes on patient and you're seeing them in clinic and they've got a BMI of 45 or 50, please think about the person doing that echo and ask yourself, are they really going to get diagnostic images on this patient? Even with Sonoview, are we really going to get someone with this patient? And if they've got a huge BMI, think about something else like a mugger or a CMR. Think about the person doing the scan, because you don't want to send a patient for a scan, wait a long time for it, and then find out it's non-diagnostic. So look at the patient before you request an echo and just think, is this going to be feasible? And also with non-cardiac surgery, you'll get a lot of phone calls from the orthopods and anaesthetists about a patient with a murmur, and they've come in and we're operating on them tomorrow, we need an echo. They don't need an echo. Look at the non-cardiac surgery guidelines. Valve disease patients don't need an echo unless they've got severe aortic stenosis. That's the only time you would need to do an echo, which is going to affect management. Valve regurgitation does not affect the safety of non-cardiac surgery unless the patient is in clinical heart failure. And even with LV impairment, unless the patient's in heart failure, it doesn't really make a difference. So when you get those phone calls, really ask yourself, is this really going to affect the patient's management? And be judicious and stand up to the referrers and stand up to the anaesthetists and ask them really, what difference is this going to make to the patient? And so it's always good to know the non-cardiac surgery guidelines for echo. Then you can really end up rejecting a lot of these requests that come through to you. And it will often come to the on-call reg, and you'll feel pressured by a consultant anaesthetist asking you to do an echo. So please be judicious and make your non-cardiology referrers, make them work for their echo when they refer it to you. And with writing conclusions, guys, there's an art to writing conclusions for trainees. When you're doing an echo conclusion, not everything is significant. Mild MR, mild functional MR, mild TR, these things are not significant. They're not going to ever get managed. They're not going to cause symptoms. So significant valve disease is really something where you feel that the patient needs further investigations or surveillance. So really with MR, mild TR, mild PR are not significant. They are not worthy of being in the conclusion. The only time you'll put mild MR in a conclusion is if it's organic, if it's due to prolapse, because then it could get worse. So with conclusion writing, be judicious, really talk about your LV and your RV, and with valves, significant valve disease is the only thing that needs to go in a conclusion, and that's only something that is going to need follow-up or cause symptoms for a patient. And when you get your request from cardiac surgeons or non-cardiologists that we see a pericardial effusion on CT, please echo this patient. Please remember that a CT will always overestimate the size of a pericardial effusion because it's going to be non-gated if it's non-cardiac. And you measure your pericardial effusion in diastole. Unless they happen to just acquire that slice during end diastole, a CT will 99% of the times overestimate the size of a pericardial effusion. So always bear that in mind when you get an echo request for that. So these were just some practical points, probably mainly for the trainees here. So these are some guidelines I wrote. They're very small, but these are the COVID inpatient guidelines that I've written for my hospital, because we know a lot more about COVID now, but COVID is risky for the person doing the echo. You spend potentially 20 or 30 minutes with your arm wrapped around the patient and in their breathing space. So with inpatient echo, please ask your referrers, what is the patient's COVID status? If it's negative, then you just crack on and do your echo as normal with basic PPE. But if the patient's COVID status is positive, then you really need to be careful, and you really need to ask yourself, is this actually going to affect the patient's management while they're in hospital? And these are the main indications that I've written for my hospital where it will, and that's based on the guidelines and the evidence base in COVID. So not everyone with a positive COVID status really needs an echo. Otherwise, you'll be snowed under with every patient with a troponin rise getting a suspected myocarditis echo. So with heart failure, we only do echoes if they've clinically got heart failure and their NT-proBNP is up. With the suspected myocarditis, it's very, very common to get troponin rises in COVID. So we've selected that only if the TNT is more than 100 and they've clinically got heart failure and they've got ECG changes, will we echo that patient. Anyone where that isn't the case, it's unlikely to be myocarditis. So really be judicious. And if someone has COVID and you do a transthoracic echo, you need to be in and out quickly. And you need a machine and equipment that can be wiped quickly. So we employ the BSE guidelines, which are for COVID positive patients, you do a level 1 echo, which is a quick echo, which takes 5 minutes with a handheld machine that can be wiped clean instantly, and you do a targeted echo report. And that's all that is needed on that patient. And the only situation where we don't do that is for endocarditis. We take a portable machine for that patient because you need higher image quality. But when you get inpatient requests, please ask the referrer the COVID status. And if it's positive, you really need to be careful about whether that echo actually needs doing. And if it does, it's got to be a target quick scan. And in 2 or 3 minutes, you can actually get a lot of information about the heart and the valves. So this is a typical echo report at our hospital. This was just an echo done by one of our registrars on a patient who came in with a Minoka, and really what the question was, what was going on. So this was a patient who then went on to have an MRI, and Takotsubo was the main sort of possibility here because the apex was dysfunctional. But really, we comment on the quality of the echo, then the LV and the RV, and then I normally talk about valve dysfunction. And the key thing here is this patient has got trivial regurgitation. These things don't go in the conclusion. Just keep it concise in the conclusion. And one thing that I do in my all echo, CT and MRI reports that I do is when we do echoes, we should think like a cardiologist and think like a referrer. Not only do the conclusion, but what I find is really valuable after that is do a sentence or a small paragraph, putting your thoughts together and actually telling the referrer what is going on overall. Put yourself in the referrer's shoes and ask yourself as a cardiologist, or non-cardiologist, if I get this report back, what do these things actually mean? What is actually going on with the patient? And I do that on all my reports, and I find it useful, and I think it's a good thing to do. It takes another minute or two on your report. So just wrap your thoughts together as a doctor, as a cardiologist, and let the person who's referring then give them an overall summary sentence as to actually what is going on with this patient and what should they do next, because that's the question they want to know, especially for non-medics. When you put about LV, non-cardiologists, LV, RV, mild AR, their question is really, okay, what does that mean for me? What do I do with this patient? So I always find this is very useful, just an overall sentence at the end, putting your thoughts together. BSA, absolutely critical. There's no excuse whatsoever not to put the BSA in for a patient. So that's really the main bit of transthoracic echo, the biggest sort of single section of the talk. I'll talk about the more subtle, the more advanced types of transthoracic echo now. So strain imaging, you may have heard of this. Your ways of assessing LV function, visual is the crudest way, and then you have ejection fraction, which is a basic quantitative method, which is helpful. The data is based mainly on that, and it's very, very powerful. But we have more subtle ways of looking at systolic function now. And this is strain imaging. Strain imaging is deformation imaging. That basically looks at your myocardium on an almost sort of microscopic level. And because you can get systolic dysfunction, and quite significant systolic dysfunction, even while your ejection fraction remains normal. Strain will look at deformation. It will look at each sort of chunk of myocardium. It divides the heart into tiny little chunks of myocardium called speckles, and it looks at the deformation. It looks at how much each of those cubes of myocardium squashes down and changes in size and shrinks in size. And that's called strain. And it's usually longitudinal strain is the one that we have most data for on echo. So that's the sort of longitudinal squashing of the myocardium. So this breaks down the ventricle into tiny segments and looks at the deformation and squashing of each of those. And that's why it's a negative number, because the cubes or the speckles of myocardium get smaller. And this is very, very accurate, and it's subtle and it's very accurate, and it predicts LVEF drops and heart failure very powerfully. And you can get significant systolic dysfunction even while your ejection fraction remains completely normal. The patients where this is the most important are the ones where you're looking for very, very subtle changes in ventricular function, where you're doing careful surveillance. And there's no more important group than the cardio-oncology patients. Cardiotoxicity can happen with certain chemotherapy agents. Type 1 cardiotoxicity is what you get with your anthracyclines. Type 2 is what you get with Herceptin. Type 1 is really bad because when you get it, it's irreversible. The heart failure that you get from anthracycline chemos is the worst of all. You can't do anything about it. It's complete necrosis of the cells. So with cardio-oncology patients, the old way of waiting for the heart's ejection fraction to drop below 55 and then you see them and then you start stuff, that is useful, but we can do better than that now. And the aim with these patients should be to detect LV dysfunction before the ejection fraction drops. And that's why we look at strain. So with cardio-oncology patients, for example, if you get a relative reduction in global longitudinal strain by 15%, then that is classed as significant systolic dysfunction, and you get in there and you get them on cardioprotective medications ASAP. And you do that regardless of what the ejection fraction is. You don't wait for the ejection fraction to drop. And this significantly benefits patient outcomes. So strain will allow you to look at very subtle changes in systolic function before ejection fraction drops, and it's really important. You don't need to do it on every patient. It takes a little bit longer to analyze, but do it on the ones where it will make a difference. So your pregnant patients, if you're looking for changes during pregnancy, serial changes for peripartum cardiomyopathy, or really cardio-oncology patients especially. And it's quite easy to use on the Philips machine. You don't have to acquire any extra images. You can post-process strain on the images that you require in your 2, 3, and 4 chamber long axis images at the apex. And you can either measure it on a segmental basis or globally. And it's very, very good for picking up regional wall abnormalities, even when you can't see them by eye. Often, for example, in amyloid patients, they get a base to apex gradient where the base is much worse affected than the apex. And you can pick that up very quickly with amyloid patients, even before you see it visually. So strain is something you'll get used to seeing, and it's a very sort of accurate and subtle way for looking at subclinical systolic dysfunction. So I'll stop there at TT for a sort of 5-minute break. I think that is probably a good bit of timing. That's the sort of main first third of the talk. We're at about half an hour. So I don't know, do people want to ask questions over the next sort of a 3 or 4 minute break, or if you want to just stretch your legs and come back in a few minutes, I'm happy. I'll stay here and answer any questions for the next sort of 3 or 4 minutes before I go on for the rest of the talk.
Can I ask a question, Dr. Jamal?
Yes, of course. Yeah.
In my trust, they're not doing strain calculations as much as in other places. Is this something you think that we should be competent in as trainees training in echo, and we should be regularly reporting this?
So it's a good question. So I lead my cardiac imaging service, and even in my hospital, we're not doing it routinely at the moment. I've been there for about 1.5 years and try to sort of make lots of changes. And this is one of the ones that I'm trying to bring in and bring home quite aggressively. So strain is not new. It's been around for a long time. And it was always seen as a research tool, in inverted commas, which made no difference to patients in real life. But now we're seeing that strain actually has a big clinical impact on patients. So it's going to be used more often. And importantly, it's getting much easier and quicker to analyze. Speckle tracking used to take a long time to analyze and the tracking wasn't good. But now with more competent methods called feature tracking, it can be done literally within about 2 minutes. And the learning curve is speeding up as well. Everything's getting automated, and there are now auto strain packages. And the worry always with a new technique is your intra-observer, and test-retest variability. So that was always the thing that put people off strain. It's going to take ages to learn. There's lots of variability. Is it just a research tool? But that's changing a lot now. And cardio-oncology is the thing that's pushed that forward. So you'll find now that strain analysis will become part of routine packages on echo. It'll be very quick to do with a couple of dots drawn, and the machine will track it automatically with very little user interface and input needed. So as that comes on, you'll find that I think over the next 1 to 2 years, it'll become much more common. And I imagine in about 2 years from time, it will just be completely commonplace. Everyone will be doing it, maybe even earlier. So if you have the availability for it in your hospital, yes, just start practicing using it. But I think any new thing that is rolled out, so when we roll it out, it's got to be done carefully. If you just start doing strain analysis on people and putting it on reports, it's going to confuse the referrers, because even your cardiology colleagues won't have heard of this generally. So I think what I would say is get used to just practicing using it if you're training an echo. It's a good skill to have, but the best way to bring this through and put it on reports is really for your hospital needs to have it, and your echo department needs to train your non-imagers, give them a talk on what strain actually is, how to interpret it, and then you need to decide as a department how you're going to express that report and what is going to be your normal value for that department, because every vendor has a different value, and the value always was seen as -20, but it should be the mean -2 standard deviation. So for Philips, the mean is 19.5 and the standard deviation is 1.7. So usually for Philips machines, you need to class your lower limits of normal as the cutoff for abnormal. And the lower limits of normal should always be the mean minus 2 standard deviations. So for Phillips, therefore, it's about 15.5%. So I would say with strain, get used to practicing. There's no harm in doing that. Get skilled with it. It's going to be very easy to learn now, but to roll it out and before you start expressing it in your reports, you need to let your non-imaging referrers know what strain is. A short talk is all that they need to, because you don't want to put things in reports that confuse people, because when people get confused, they lose faith in your modality. So I think educating your referrers on strain and then getting the reps in, getting the reps to show your trainees and CPs how to calculate strain, then decide as a department what your lower limits of normal is going to be, and then you can start expressing it and putting it on reports. So I hope that's helpful.
Thank you, that's great.
Sorry, hi. You mentioned that you need to have radial and longitudinal values before you can actually label an ejection fraction as normal. So do you routinely do MAPCs in your center, or would you recommend we do them?
So when I said about, for radial and longitudinal, you don't need that for ejection fraction. For normal systolic function, absolutely. Systolic function is not normal unless radial and longitudinal are both normal. You can get completely obliterated longitude. So in your amyloids, for example, amyloids will have a normal ejection fraction to start off with. Their radial function will be good, but they will have zero longitudinal function. And there is absolutely no way whatsoever that ventricle has normal systolic function. So yes, I would do radial and longitudinal. And longitudinal, I would use MAPC and I would use a TDI, your S-wave velocity at your lateral annulus. And these are things that should be done routinely. They're very quick to do as well. And the other benefit of that is longitudinal function often goes before radial function, and that can be your early marker of dysfunction. But yes, I think radial and longitudinal function being on reports is an absolute minimum. That has to be there, really.
Do you predict MAPC would be useful in predicting onset of HFpEF?
I don't know the data on that. I'll be honest. I don't know if longitudinal function is specifically or commonly impaired in HFpEF patients. So I don't know the answer to that. I would say the best ways, if you want to look at subtle ways of looking at the onset of HFpEF, would be to look at your TDIs. TDIs are brilliant. They're like a subtle way of looking at diastolic and systolic function. So they're sensitive at looking at longitudinal function, and your E-wave velocities are very good. So if your E-wave velocities are less than about 7 centimeters per second, I would say that's a much better way of looking at early onset of diastolic dysfunction. I would say longitudinal function probably isn't that useful, but your TDI, lateral and septal S-wave velocities will be. Sorry, your E-wave velocity, my apologies. And I'll just go back 1 or 2 slides. So if you look here, so your septal E-wave velocity of less than 7 or lateral E-wave velocity of less than 10, they will be good subtle markers because your overall E-wave velocity may still be more than 4, maybe less than your average E. So your average E over E prime could still be less than 14, but these things will be the subtle markers of diastolic dysfunction. So the simple way would be to do TDI and look for your reduction in E-wave velocity. The even more subtle way, which is out of the bounds of this talk really, and I don't wish to confuse people, would be with strain. So strain can look at diastolic function with the peak early diastolic strain rate. That's a really sensitive thing. And maybe those things will come in when strain becomes commonplace. But I think for early diastolic dysfunction, your E-wave velocities will be a good place to start on TDI. Your E prime velocities on TDI. That would be a good subtle early feature of diastolic dysfunction coming on.
Thank you.
So any more questions? And I'll go on to the next part, which will be sort of complex echo. Okay, so I'll move on. So I'll go on to TOE. So TOE is sort of non-invasive. It's still, it's like having an OGD really. It's that level of invasiveness. So really simply, TOE should be used. It's not going to be a first-line test. It's not pleasant for the patient to have done, but it's at the same time, it's extremely powerful as well. And it really should be done where you can't answer the question with transthoracic echo or with another modality to the same quality as TOE. So the mainstays of TOE are all based on 2 things. Firstly, the probe is behind the heart and very close to the heart. The esophagus is about 2 millimeters away from the left atrium. So you get very close to the back of the heart. So it's brilliant at looking at the left atrium, the mitral valve. And because you get so close to the heart, you have very good spatial and temporal resolution, but most importantly, you have very good signal to noise. And that's the key with transesophageal echo. And that's why the image quality is so good. And that's why it's so good for TOE. So the main indications really for TOE, I think, are endocarditis. In patients where your transthoracic echo is very abnormal, or if it's normal but you have a high suspicion. You have 95 versus about 70% sensitivity for looking at vegetations. It's excellent for the mitral valve. I am encouraging our surgeons really that for mitral valve surgery, all patients should have a TOE before, because the 3D echo that you can produce and the 3D data that you can produce on the mitral valve is fantastic. The surgeons can get so much information before they enter the patient, and so much intricate information that really is important to them at the time of surgery. It's very good for prosthetic valves. You get less of the shielding. It's very good for 3D, and it's very good for the left atrial appendage, because that's traditionally very, very difficult to see on a transthoracic echo. And it's very good for intra-procedural advanced structural interventions. So really, it's like having an OGD. For those who haven't seen it, if you look at it from the end of the bend, it's the same size of probe. It's just you've got an ultrasound rather than a fiber optic. And you see, this is where it goes. And 80% of the scan is actually done in the esophagus. In the lower, the mid esophagus is probably where about 50% of it's done. About 10% of the scan is sort of lower esophagus and upper esophagus, and then about 20% of the scan is done in the stomach. Most of it's actually mid-esophageal. You don't have to go that far down. You can see mid-esophageal is where you're getting all the business really close here. So we don't, the stomach actually provides sort of a minor part of the data, but obviously very important aspects. This is actually a transgastric view from inside the stomach, a short axis of the LV. So the TOE probe is it's very steerable. So you have different ways that you can look at different parts of the heart. So you can rotate the probe, you can change the angle at which the head is pointing, you can flex and extend the probe, you can put lateral tilt onto the probe, you can change the depth of the probe. So it is really it's a really great technique for the right indication, and for the right indication, there's nothing that can beat TOE. So I do a lot of 3D TOE, and this is a patient that I presented in a webinar a few months ago on 3D echo, and this just shows how useful 3D is for those who aren't familiar with it. There is that misconception, and I found this when I started my job, that the 3D TOE operator was just the pretentious imaging specialist who liked to look at pretty pictures and show nice, fancy volume rendered images, but it was nothing more than that, and it was just eye candy, really. And that's a big misconception. 3D echo is the game changer. For certain patients, 3D echo is the difference between getting a diagnosis and not getting a diagnosis. It's the absolute game changer. And the volume rendered image that you produce, this image here, this fancy 3D image, this is not even just the tip of the iceberg. This is just scratching the surface of what 3D can do. The real power of 3D is the quantitative 3D analysis that you get. This stuff that you see here that people think is 3D, this is nice, but this is about 5% of what 3D can really provide to you. So 3D echo is where you acquire a volume. So when you acquire 3D echo, it's like the difference between, if you have a box of cornflakes, the front of the box is like a 2D image. A 3D version of that will be acquiring the whole box, the whole cuboid. So when you acquire a 3D image, you tell the machine basically how much of the front of the box you want, and then how much of the depth you want. You tell, that is programmed into the machine very quickly, and then that produces a volume. It's a full volume, it's a volume of data that you're acquiring. And the benefit of that is, it's the difference between, say, looking at the front of the box of cornflakes and basically having the whole box in your hand. And once you acquire that volume, you own everything inside that volume. That box of cornflakes is yours. You own it, and you can post-process it, and you can look at anything inside that structure from infinite angles. You can rotate it, you can crop it, you can chop bits away. And it's really, really powerful. And this is a patient that I had. He was a guy with who was labeled, had a transthoracic echo. It was labeled as at least moderate mitral regurgitation due to mitral valve prolapse, but they couldn't quantify it any further. It was an extremely eccentric jet. And you'll see that quite commonly with these very eccentric jets. You will be able to get a PISA, but you will struggle to get a VTI. And because of that, you won't be able to provide an EROA. And one of the things for me as an imager that makes me slightly, I wouldn't say annoys me, but is one of my bugbears, and all people have their bugbears, is there is no such thing as mild to moderate. There is no such thing as moderate to severe. It is black and white. mild, moderate, severe. There's no such thing as in between those. And you have to be absolutely explicit, because the difference between moderate and severe is the difference between getting intervention and not getting it. And sometimes on transthoracic echocardiography, you cannot say that with absolute explicitness. And especially with your very eccentric jets, that's the typical situation. It's no use for me having a report that says at least moderate. I have no idea whether that's moderate or severe. I have no idea whether I need to intervene on that patient. I want accurate data. It's the difference between the patient getting treatment or needing intervention and not needing it. So that sort of situation, moderate to severe, is not helpful and it's not good enough. We can provide better than that. So this is a 3D TOE I did on this patient. So firstly, I acquired 3D volume of the left ventricle. So we acquire it in two views. And this is like the front, this is the side. It's orthogonal. This is like a 4-chamber and 2-chamber, and then you get a full data set. And this provides very accurate volumetric analysis. So immediately, I knew that this patient's ventricle was mildly dilated because indexed for his BSA came at about 90 mils per meter squared. So immediately, just from one acquisition, I got the data. So it's all about the quantitative data. So, and this is much more accurate than Simpson's because you've got a whole volume. You're not making assumptions. It's tracking the whole of that ventricle in systole and diastole throughout the cardiac cycle. And it's much more reproducible and comparable to CMR, which is the gold standard. So 3D is great for the ventricle. So that was the first part of this scan, showing the power of 3D. So we got accurate ventricular information. So he had a mildly dilated ventricle. Immediately, he has a class 1 indication for surgery if this is severe. And this was the jet on the 2D image. You can see it's a very eccentric jet here, massive PISA, but very eccentric. And when I quantify mitral regurg, what I really want is an EROA. Like with AS, I want an AVA for AS, and I want an EROA. EROA is the gold standard number. That's the one we really want. And you won't get that unless you can get the full envelope on VTI, and you'll struggle with eccentric jets on MR. On TT, this is the beauty of 3D echo. There is no jet in this world that is too eccentric for 3D echo to analyze and give you an accurate EROA on. So when we do 3D echo, we have a number of stages. The first stage is the volume rendered image. This is really helpful. It gives you lovely 3D, like a video 3D. It's very powerful for intra-procedural TOE, for cath lab procedures like appendage closures, ASD closures, those sort of things. So it's like having a video camera inside the heart. And it's very good for giving you sort of good, almost like a really nice moving 3D image. It's like a video camera inside the heart. So it's very nice for looking at anatomy. And you may appreciate here, aortic valve, mitral valve, anterior leaflet, posterior leaflet. Can you see this thing flicking up here, this stringy thing? So that is ruptured chordae on the P2. And immediately when you get ruptured chordae, you're thinking about flail. Flail is usually caused by ruptured chordae. So immediately we have in our mindset that this patient may have flail of the posterior leaflet because we can see a redundant ruptured chordae here. And so that's the first type of 3D information you get. You get a nice volume rendered image, but this is really scratching the surface, as I said. The quantitative information is what really gives you the power of 3D. So if you do 3D echo and you just provide this, you've not really provided any service to the person referring it to you. This is not what 3D echo is about. This is just the surface. This is what 3D echo is about. It's all about quantitation, because when you own that data set, you can then analyze it in extreme detail. You can reconstruct the image in any plane you want from infinite angles. So what we can do is we can build up and track along the annulus. We can build up a model of the mitral valve. So you can beautifully see here, you've got flail that's pointing up, flail of the P2 and P3 scallops here. So you've got two scallops involved. You know exactly which scallops are affected. You know it's flail. And this data, I'm sorry, it's very small to see, but you get a lot of information for the surgeon. You get very accurate annular information. You get leaflet lengths, prolapsing heights, tenting volumes. These are all things that are very important for the surgeon to work out whether they repair or replace this valve and how they repair it. This is the stuff that's very, very important to surgeons. And then we can post-process our data set. And this is how we find out what the EROA is. We have a very eccentric jet. You can see going in an extreme direction. Because you own this whole data set, you can then reconfigure this data set in something called an MPR. This is a multiplanar reconstruction. We have different planes, and we I won't go into it in any more detail than this for this talk, but you can spin the image around, reconstruct it from any angle, and you can look at anything from any angle. And what you basically do is you reorientate that jet of MR so it's coming out towards you, towards your face. And that's what we do here. So this is the MR jet. We get it in one angle view, we get it in the other view, and we orthogonally cut across the vena contractor, because a 3D vena contractor is the EROA. And this image here is the EROA. This is that jet of eccentric mitral regurgitation reorientated so you're looking down it at the barrel. This is the jet that is coming out at you. And we trace around that, and that gives you the EROA. So from a transthoracic echo with a possibly dilated ventricle, at least moderate MR, we can provide a lot of information. So we have a mildly dilated ventricle with normal systolic function, mildly dilated, immediately, a class 1 indication for surgery, P2, P3 flail with some very severe MR, and you've got an EROA. And we can give the etiology. When you talk about stenosis or regurg, in every report, you need to talk about the mechanism every time and the etiology if you can. So we've told the surgeon this is flail, 2 scallops involved, it's very severe, it's fibroelastic degeneration, and we then talk about the repairability. The repairability is based on the number of scallops involved, commissural involvement, size of the annulus. And this has 2 scallops, no commissural involvement, the commissures are not prolapsing, and the annulus is only mildly dilated at 42 millimeters. So this is a definite repairable valve. And this is one that went on for repair. So this made a difference to this patient, and 3D was the only thing that really made a difference here. You can do MR and AR fractions on CMR, which is really useful as an adjunct, but 3D echo is the key really. And I think it's not just pretentious fancy imaging. And it's taken me time to sort of change people's mindset on that. And anyone who does 3D TOE, keep pushing it. And when you do 3D TOE, show off your work at the MDT. The more you show off your work, the more people will buy into it. And when I do reports for TOE, I put screenshots at the bottom because I want people to look at that and think, look, this is really good. This is what's at our disposal. That's how you get referrers buying in. So, 3D echo is a great facility, and it's very applicable on transthoracic as well. Not as easy to do because the signal to noise is less, but it's definitely something that can be done on transthoracic, and it's something I'm training my CPs to do. So I'm just show a couple of bits of things that we've published over the last year or two, just from multimodality imaging. And this is a case where we had a girl with an aortic root abscess, and we did 3D TOE on her. She asked me to pull the probe out after about 5 minutes. So we had 5 minutes to do a detailed detailed TOE on this girl in order to plan her aortic root abscess surgery. And this is the beauty. When you acquire one volume data set of 3D imaging, you can do so much post-processing with it. With that, all of that analysis that I did earlier was just from 2 images, 2 acquisitions. So this provided a full reconstruction of the aortic root here, which had abscesses and a pseudoaneurysm, an abscess cavity in it. With one acquisition, we were able to assess the abscess, talk about coronary artery involvement, and provide detailed 3D reconstructions for the surgeons. And that was just from one acquisition alone. Then this girl came back in with a pseudoaneurysm of the same area. The whole aortic root broke down, and we used 3D TOE to really reconstruct that aorta and then provide really useful intervention, sort of live 3D interventional TOE. So 3D data is very, very important. And within 1 or 2 3D acquisitions, you can get a massive amount of data. And it's very, very quick as well. And this was a case which one of my registrars published with me. This was a patient who had endocarditis, and it was actually very difficult to tell which leaflet it was on. When you do transthoracic or TOE, don't always assume that the leaflet next to the septum is the anterior leaflet. It may not be. For example, when you look at your 45-degree view, you're actually looking at P3, A2, P1. So you may be cutting across different leaflets. It's not always easy to know exactly where that vegetation is. And this patient's vegetation was actually not even on the leaflets. It was actually on the posteromedial commissure. So he went for surgery, and this made it repairable. Because it was on the commissure, they could detach it from the commissure, and they didn't need to touch the leaflets. We had a recent one where we had a vegetation on the warfarin ridge next to the valve, not even on the valve. So this allowed us to tell us this vegetation was actually attached to the anterolateral commissure, which gave the surgeon a heads up on what to expect when they opened the patient up, and actually made it a much more repairable valve. So these are some images from 3D TOE. These are TOE indications for those who don't practice TOE. So this is I'll sort of move quickly through things. This is the left atrial appendage. with the thrombus sitting inside it. So this means you don't cardiovert this patient. So it's very good for the left atrial appendage. If you need to do a TOE guided cardioversion, or prior to any sort of transeptal puncture or left atrial appendage procedure, they have to make sure there's no left atrial appendage thrombus. It's an absolute contraindication for any sort of device closures or left atrial appendage closures. So it's very good for the left atrial appendage. Very good for endocarditis. This is the patient with horrible destroyed mitral valve leaflets. The sensitivity for endocarditis detection on TTE is 95% versus 70% for transthoracic. And you can see vegetation is down to 2 millimeters, and you can characterize them, as we've said, in a lot of detail. Very good for intraprocedural procedures. So this is the patient having a mitral clip. So this is the introducer and the system going through the mitral valve. So it's very good for interventional structural interventions, like having a video camera inside the heart. Very good for prosthetic valves. So this is a bileaflet mechanical valve. And you can see this is a mitral valve. This is looking at it from the left atrial side looking down. So you can see the resolution. You can see the stitches on the sewing ring. And you can see a paravalvular leak here. So again, these images are only the surface. This scan then is quantified, and then you reconstruct that paravalvular leak, and you can provide deep data to the interventionist on the size of it, the shape of it, the length of it. This is the patient who has mitral valve prolapse. So this is how we track the annulus. We track it all the way through the cardiac cycle. We trace around the leaflets all the way through the cardiac cycle to give us these really accurate models of the valve. And this is more intraprocedural TOE. So this is the patient with a secundum, small secundum ASD here, you can see. And this is the device closure of that. So this is a small, quite superior secundum ASD. It's not a PFO, it's an ASD, this continuous flow. And this was very, very useful for guiding the interventionist. And also for ASD, when you do TOEs for ASDs, prior to closure, you really should be doing 3D, because you need to measure all 6 rims. And the most accurate way of doing that is on 3D, because if you measure them on 2D, it will all depend on the cut that you take. And you may underestimate or overestimate the size of a rim based on the cut that you take. So 3D is more than just nice visual images. It really is a important quantification, and I use 3D on about 95% of my TOEs. So going on to stress echo, this is talking really about function of the heart. This is a functional test, so mainly looking for ischemia, but also for viability. And then we have non-ischemic stress echo. This is a powerful resource, and this is not done that often. This is something that I'm trying to bring into my hospital and start this within the next month. So most people know about ischemia and viability, but the non-ischemic, the non-coronary indications for stress echo are actually the most exciting ones and the most interesting ones, and they are really exclusively done with exercise. You can see stress echo for coronary disease can be dobutamine or exercise. They both have their pros and cons. Exercise is more physiological. Dobutamine is faster to do, there's more throughput. Problem with exercise is once the patient comes off the treadmill or their heart rate drops very quickly and you may not be at peak stress. So stress, if you're going to do exercise, treadmill is not great. Bike is better because you can continually scan. Then the bike setup, this is the one we have. This is a semi-recumbent bike. So stress echo really is looking at coronary artery disease. And for ischemia, you're looking at changes between resting and stress wall motion. This is wall motion based in the vast majority of cases with stress echo. So you're looking at the heart at rest, and then you're doing light exercise or light stress, and then you're doing peak stress here. So this is just rest versus peak. So we normally do 4 stages. We do resting images, then low dose images, let's say 10 mics per kilogram per minute of dobutamine, and then we do our peak images, and then we do recovery images afterwards. And because we know that different segments of the heart are affected by different coronary arteries, we're basically looking at the difference between rest and stress. And the definition of ischemia is basically where segments get worse at stress than they are with rest. So either a segment goes from normokinetic to hypokinetic or akinetic, or it goes from hypokinetic to akinetic. And based on the number of segments and the distribution of the segments, you can work out the degree of ischemia and which coronary artery is likely to be affected. And that's really the premise of stress echo. And you can see here that this is a negative stress echo at the top, 4-chamber, and the rest and peak images. So oh, actually, there are two positive studies. So this is one patient. You can see at rest, everything's contracting well, but at peak stress, the lateral wall is becoming hypokinetic and actually akinetic. So this is circumflex ischemia. And this is another patient who you can see at rest, you've got good contraction, but at peak stress, you can see the inferior wall is becoming almost akinetic. So this is RCA ischemia on this bottom patient. So stress echo really for coronary artery disease, that's the main indication for ischemia. That's probably about 90%, 95% of stress echo is for coronary artery disease looking for ischemia. And it's usually done with dobutamine for logistical reasons, but it can also equally be done with exercise. And the definition of a positive stress echo is where you have two or more segments. Yeah, two or more segments in the same coronary artery territory. One segment alone is not positive. It's non-specific. It's unlikely that you'd get a significant defect in a coronary artery and only have one segment affected. Image quality is important. You want the ventricle to be seen as best as possible. So we do all of our stress echo with contrast. You want to give yourself the best chance of looking at wall motion, because remember, at peak stress, the patient's breathing, the heart rate's 2 or 3 times faster, and it's going to be much harder to get your images. So we use SonoView on all patients unless they've got really brilliant image quality. This is the typical report of a patient I did. So really, we're wall motion assessing throughout the stages. So rest, low dose, and peak stress. We do recovery as well. I didn't put that on because there wasn't enough room here. And you can see here, you've got wall motion abnormalities at the start, inferiorly. So there is here, you've got what is really a subendocardial infarct here, because it's moving. Because it's moving, it's viable. And then recovers with low dose. So that shows as contractile reserve. But then at peak dose, you get worsening wall motion abnormalities. So peak stress, it doesn't have to be normal to start off with. It's where you get worsening wall motion with peak stress. And this patient had a 99% mid-RCA lesion. So really, we talk in my reports, we talk about the LV size and function at rest. Then we talk about symptoms. Then we talk about wall motion abnormalities. Then we say if it's positive or not. And then really putting everything together to basically let the referrer know what's going on. And I always ask for correlation for invasive angiography whenever I have positive DSEs. That's
Dr. Jamal?
Yeah.
Sorry to interrupt you. We've got a question from Dr. Jalani saying, what is the importance of the recovery images?
Good question. I'm glad you asked that. I always ask my trainees that. So recovery, people often say, why do you need to do recovery imaging? If the LV is normal at rest, it's going to be normal at stress. Why do you need to do recovery? Just get the patient off the table and get them home a bit quicker. With recovery imaging, you're looking for something called transient ischemic dilatation, and it's quite a rare phenomenon. And it's like balanced ischemia on a stress MPI. You can get a situation, it's very rare, where you can have actually normal wall motion at peak stress, but actually have multivessel disease. So in multivessel disease, in a very small subset of patients, you can actually not get wall motion abnormalities at peak stress. And instead, what you'll see is ischemic dilatation. So in recovery, the LV will get bigger by 20%. And the function may be normal all the way throughout. But if you get ischemic, if you get dilatation of the ventricle in recovery, that is actually a subtle feature and a known feature specific to multivessel disease, which happens in a very small subset of patients. You can get the absence of peak stress-induced wall motion abnormality, but you can get transient ischemic dilatation. So that's why we do recovery imaging. It's rare. I have about one maybe, or once or twice, 2 a year cases. But it's the equivalent of like balanced ischemia on MPS. So it's a rare phenomenon, but that's where we do recovery imaging. And recovery imaging should be done when the heart rate's less than 100 beats per minute. For throughput, I give everyone metoprolol IV after peak stress just to get the heart rate down quicker, get the patient out 10 minutes earlier. That's the difference between maybe getting 4 or 5 or 1 extra patient on the list. So yeah, it's a good question. It's always the obvious question.
Thank you. We have, thank you very much, Dr. Jamal. We have one more question from Dr. Nishtar. He's asking, when would you prefer stress echo over CMR?
Okay, that's a good question. So I think the answer here is all about what's available at your hospital. So what test you go for all depends about what's available at your hospital. I'm an echo, CMR, and CT person. I don't request MPI on any of my patients. The reason is because so when I choose modalities, I don't do MPI on anyone. MPI has low spatial resolution compared to MRI. MPI can get ballast ischemia, and you very often with MPI get this 4 to 5% small defect. And the question is, what does that actually mean? And you get this non-significant defect quite often of 4 or 5%, you see, which actually clinically means nothing, and it's not in keeping with ischemia. MPI is a very useful test. It's very, it's got a lot of data. All the historic data for stress testing is of MPI, and MPI all depends on what the expertise is in your hospital. But I don't use MPI for that reason. For functional testing, CMR versus stress echo, they're all quite similar in terms of accuracy. Sensitivity and specificity of stress echo is about 80% for both. For MRI, it's about 85 to 90% for both. So MRI is more accurate. And if you had an ideal world where you had access to MRI as quickly as you could get a stress echo, you'd probably go for MRI in everyone, because you'd not only get the stress imaging, but you'd also get all the functional data, all the viability data. It's like a one-stop scan. So for me, the main thing in real life is about what's available at your hospital, what waiting lists are like, how big is the stress echo service, how big is the MPI service. So that's the real life thing that will make you choose one or the other. But if you have to go on, but despite that, there'll be certain patients that you really want to send towards MRI specifically. And the ones you want to send for MRI specifically would be the very big patients that have poor echo windows. They would be the ones. If you're looking for something else in particular that can't be seen on an echo, so aortic disease, for example, they're the ones I would send for an MRI. So if I'm looking for aortic disease, if the patient's going to have poor echo windows, or if they've got something more subtle like a particular cardiomyopathy or extra cardiac sort of issues that I'm looking for, then I'd go for a stress MRI. But ideally you'd probably have it in everyone, but it's all about resources. But stress echo is fantastic. And the benefit of stress echo is you can add 2 more minutes onto the scan and also quickly look at the valves on the right ventricle before, and do almost like a one-stop shop for breathlessness in the same patient. But MPI, it's not, MPI is a very good test, but I don't use it personally for that reason. The reasons I mentioned, that's personal choice. Yeah, stress MRI is the most accurate of the 3. There's a lot of data for stress MRI versus invasive coronary angiography. The big studies are MR-informed, CMARC and CMARC2, and it made a big difference to patients when they compared it against standard NICE guidelines-driven management. It reduced the requirement for invasive angiography, and it's very, very accurate and led to a reclassification in a lot of patients. So the last one on stress echo is just to say this: coronary artery disease stress echo is literally the tip of the iceberg. The non-coronary, the non-ischemic stress echo is the really interesting stress echo. This is all done with exercise bikes, and we've acquired a bike, so I'm going to bring this in soon. I did a lot of non-ischemic stress echo as a trainee, and I think any trainees that are doing imaging should be adept at not only doing coronary artery disease dobutamine and exercise stress echo, but also you should get some experience in exercise stress echo for non-ischemic conditions. And also you should not just be reporting, but you should be learning to scan the patients yourself. So these are some of the indications. So for valve disease, so you would do a stress echo for valve disease in someone where it doesn't fit together. So they have moderate valve disease, but really classical symptoms. And your question is it moderate at rest and severe on exertion? Or you have a patient who has severe valve disease and you want to be absolutely sure that you are safe to watch and wait. So you do exercise to look to see if they've got any true symptoms, but also there are high-risk markers on exercise. So for the mitral valve, for example, if your systolic pulmonary artery pressures go up to more than 60, that is a high-risk feature, and that's an indication for surgery itself. So it's for non-severe symptomatic valve disease or severe valve disease when you want to be safe to not do anything. You can use it for teasing out diastolic dysfunction. It's good for athlete's heart. So athlete's heart versus DCM, that's a common question. Which one is it? You can ask the patient to detrain and re-scan them with an MRI 1 year later, but the professional athletes and the ones that like it, they're not going to detrain. Stress echo is very useful. If you do a stress echo on a patient with suspected athlete's heart versus DCM, your athlete's heart will have a supernormal VO2 max. They will have an increase in strain by more than 13%, and they'll have an increase in ejection fraction to more than 63%. And that will be the difference between an athlete's heart and a DCM. And it's a big distinction to make. It's very good for HOCM. Your gradients on HOCM should not just be assessed at rest. You need to do them on Valsalva, sitting and standing. But importantly, if you have someone who you suspect may have a significant gradient, someone with symptoms with HOCM, but they're not getting significant gradients on transthoracic, you really then need to think about exercising them, because it could be the fact that when they're exerting themselves, the gradient is going above 50, and that's a severe, that's the classification as severe LVOTO. So exercise-induced LVOTO should be done in HOCM patients with symptoms where you suspect it actually may be significant, because if it is significant, that will intensify your treatment and maybe think about intervention. And the last one is pregnancy. This is actually dobutamine. Peripartum cardiomyopathy, it's more likely to happen with successive pregnancies. A very good way of risk stratifying these patients. If you do a dobutamine stress echo on a patient who's had peripartum cardiomyopathy, who wants to have more kids, if you have an ejection fraction increase of more than 5%, that shows contractile reserve, and that's a very good prognostic feature, especially if the ejection fraction goes to above 55%. So there's a lot more to it than just coronary disease. Next one is contrast echo. I'm going to go through this quickly. This is either contrast for opacifying the left ventricle. That's this thing here. That's the sonoview that we're using here. So that's to make the left ventricle look better, to look at the walls better, or to look for thrombus. Or the other type is what we call bubble echo. So contrast echo is not just, there are two main types, and we should be more particular in the way we describe them. So this is called left ventricular opacification contrast echo, and this is called saline microbubble contrast echo. And this is really, as you'll be aware, to look for shunts, small shunts, so your PFOs or occult ASDs, or it's good for extracardiac shunts like big pulmonary AVMs. So you really need to look at where it's positive. So if it's positive within about 3 beats of the contrast coming in, then it's coming from the intraatrial septum usually. If it's more than 5 beats, then it's going to be coming extracardiac from the pulmonary veins. But again, it's not just about a positive or negative bubble study. There's more to it than that. You'll get a lot of patients where they have some bubbles going across, but the question is, what does it mean? So with PFOs and cryptogenic strokes, a proper positive study that has a difference for the patient is one that is strongly positive, and that's dependent on the number of bubbles. So if there's more than 30 bubbles that go across within 3 beats or 3 to 5 beats, that is a significant PFO, and they're the ones that the data is there for closing. If it's just 5-10 bubbles, and that's not a significantly positive bubble test, and you're probably going to go for anticoagulation in that patient. And with pulmonary AVMs, you'll often see a little bit of bubbles coming back for 2 or 3 minutes from the pulmonary veins. That is not positive. A positive bubble study for a pulmonary AVM is one where the pulmonary AVM is significant enough to be closed off. And that'll be one, and I was taught this by Pete Wilmshurst, who was like the god of bubble echoes, and he told me that really, if an AVM is significant enough to close off, you need to really fill the left heart completely. It needs to fill the left heart. And that's a more significant one. So if it fills the left heart 6 or 7 beats after contrast, then that is a significant pulmonary AVM, and you're normally going to see them on the CTPA anyway. So it's really about sonoview, LV bubble, LV contrast or bubble contrast. And really pay attention to when you do this, be meticulous, do it at rest, and then do Valsalvas. And the important thing with Valsalva is you need a good Valsalva, and you need to make sure that when they release the Valsalva, you see the septum deviate. If it doesn't deviate across, then the Valsalva is insufficient and you could miss a defect. So that's echo. I'll go through the last modality, sort of like I'll stop at 9. I won't do questions at the end actually, or I'll keep 10 minutes for questions at the end, because it looks like people are asking questions as we go along. So I'll finish in 2 hours, but I'll extend the talk a little bit for that reason. So the last bit is really sort of 40 minutes is going to be on the other modalities. And they're all as important, but echo has just got, it's so much more commonly used, and there's more types of it, and you should have a better understanding of echo, and I wanted to dedicate more time on that. So MRI is the second modality that I'll talk about. So this is really where you're putting a patient in a magnet to get pictures, and to keep the physics simple, you need something that is present in every cell that will be attracted to the magnet, and that's water. Water is H2O, so you have a proton in every cell in the body. So that's how MRI works. The magnet is attracted to protons. And what normally happens is when if you're lying on a table, for example, all of the protons in your body are pointing towards the Earth's magnetic field. They're lazy, they're just chilling out. What MRI does, it applies a radio frequency pulse, which is that noise that you hear, that flips the protons. Then you turn off the radio frequency pulse, and the protons flip back to normal. So when you flip the protons, you basically give them lots of energy. And then when you turn off the radio frequency pulse, the protons relax and go back to their lazy default position. And what happens is you give off energy, you give off radiation, and you give off magnetization. We use numbers called T1 and T2. I won't go into those in more detail because that should be a dedicated talk. But you're exciting protons, you're letting them gain energy and magnetization, and you switch off the pulse. And as they return back to normal, that energy that's given off, that magnetization, is turned by the machine into an image. And it's a calculation called fast Fourier transformation. It basically transforms that into an image. And it works on like a 3 coordinate, X, Y, Z coordinate. And by having 3 coordinates for each bit of information that's coming off the patient, you can locate exactly where that proton is in that patient to build up a map of that patient and work out where those structures are. So it's really exciting protons, letting them relax and turning that energy into an image. You can have 2 magnet strengths, 1.5 or 3T. 1.5 is the standard, 3 is a slightly stronger magnet. This is really strong. A 1.5T magnet, to appreciate the strength of it, is 6 times stronger than the magnet in the scrapyard. So you can see it never turns off. The magnet never turns off in the machine. It's super cooled and always turned on. And if you were to turn on a magnet, it would cost thousands of pounds every time to do it. So the magnet is always turned on. There's liquid helium, which is a super coolant, and it's keeping the magnet running 24/7. So that's where you've got to be careful when you go into the department. The magnet is always on and it's very strong. You can do it with and without contrast. The contrast is gadolinium, and the contrast basically lights up certain parts of the heart and certain structures to let you know about pathology. We'll go on to that in a minute. It is, as we said earlier, I think Salman asked about stress echo versus MRI. An MRI is pretty much like a one-stop shop. It'll give you everything the other ones will give you: anatomy, function, viability, edema. That's something that's really acute to MRI, a sign of acute inflammation. It's very good for extracardiac anatomy, which is important in ACHD patients. And it can actually tissue characterize, and this is the real power of MRI. You can get a good idea of what each pixel is actually made up of. Is it scar? Is it edema? Is it fat? Is it iron? Is it amyloid? And based on the properties of those cells and the images and the data we get from MRI, we can actually tissue characterize. So it's really, really powerful. Benefits that we mentioned. The disadvantages are really the cost and the availability of it, and time on scanners and capacity. So, we don't have it as available as the other modalities. Safety and contraindications. So metal is the first safety issue. So metal is absolutely fine to go into an MRI. The only metal that can't go into an MRI is metal that can move. So metal in the ears, cochlear implants, or old ferromagnetic clips in the brain, because they will move. Anything like a hip or a pacemaker, anything 6 weeks after implant will not move. It will be fixed by fascia. So it's only metal that can move, which is in soft, squidgy places like the ears, the eyes, and the brain, that can't go into a magnet. So shards of metal in the eye, if you get someone who says that, we do an orbital X-ray. Old cochlear implants, old clips, brain clips can't go in. The whole thing about pacemakers can go in. If the pacemaker is conditional, that means it can be used in a pace. If it's an MRI conditional device, that means it can go into an MRI scanner, but under certain conditions. There is no such word as MRI safe. It's only MRI conditional, and conditional means it's safe to go in under certain conditions. So we always have to have the patient at the lowest magnet strength at 1.5 T, using the minimum gradients. Gradients are the amount of magnetic energy applied, and for as short as possible. Can you scan non-conditional devices? The answer is yes. So we're going to roll this out in the next month or two. The old devices that are non-conditional are called legacy devices. They are safe to scan. There's a massive study called the MagnaSafe registry, and there's less than a 1 in 1,000 risk of these patients coming to serious harm. So that is something that will be pushed through in years to come. These legacy devices are dying out, but you still often need to do MRI, not only of the heart, but of other parts of the body in patients with non-conditional devices. So to bring that in, that's something that we'll need to go through radiology, cardiology, quips, and writing detailed sort of SOPs and things like that. But we're starting that soon. And these patients shouldn't be denied MRIs. The last one is GFR. So a GFR of less than 30 people often say you can't do MRI. That's nonsense. MRI gives contrast. The contrast is not like iodine. It doesn't make the kidneys worse. What can happen is if you've got very poor kidney function, the contrast won't wash out as well, and it can build up in the body, and in very, very, very rare cases cause a condition called nephrogenic systemic fibrosis. But the incidence of that is exceptionally rare. The incidence of nephrogenic systemic fibrosis using the new contrast agents that we use, they're called cyclical agents. They're a closed ring, so they're not going to stick to the body inside. The risk is 1 in 1. The risk is 1 in 500,000 to 1 in 1.5 million. So that's in all comers. And even in patients with severe renal failure with a GFR of less than 15, the risk is only 1 in 1,450. So when someone requests a CMR, don't worry if the GFR is less than 30. If that CMR is the best test for that patient and it's going to give you information that another test can't provide, then you will absolutely go for it and you will get it. No one will turn a patient with a GFR of less than 15 away for an MRI. If you can justify that this test will help the patient or make a difference to the patient and it's the best test for that patient, you will get it. The risk of them not getting the MRI is going to be much higher than the risk of NSF of 1 in 1,500 with a patient with severe renal failure. So this red mark has appeared. I don't know if someone's drawn that on my thing. I'm not sure that's going to now remain on all of these slides, I'm afraid. I'm not sure who has put that marker on there, but I can't get rid of that because it's not myself who's drawn that on there. Someone's name popped up earlier next to it. I don't know if that person, who that is, if they can kindly delete that, but if not, we'll carry on. So these are the main indications for MRI. And you can see, I won't sort of talk through them all, but there's a whole host, and the key ones is excellent for heart failure patients. You can do a one-stop scan. We do a cardiomyopathy protocol that will look for cardiomyopathies, infiltration. You can stress them in the same scan, so you can look at all the causes of LVSD, including coronary artery disease. If someone has no inducible ischemia and they have no subendocardial infarction, then that patient is pretty much not going to have coronary artery disease. There's going to be a tiny chance of a false negative. Very good for specific cardiomyopathies. I'll talk about that in a moment. Good for function. If you can't get echo images, it's good for that. It gives you everything on echo all and more. Excellent for the aorta because you can get 3D imaging of the aorta. So Mohammed, I think someone's put a green line here. Guys, can you kindly not put these markers on my slides, because I think it'll make it difficult for the guys that are seeing them if it obscures something important. It's excellent for myocarditis because it will you'll work out, based on the pattern of scarring that you see on late GAD images, you'll be able to work out the pathology. I'll go on to that on the next slide. Excellent for congenital, because congenital disease affects things in and outside the heart, and very good for masses because of the tissue characterization. So this is a typical MRI. You can look at the image quality. So if you do echo, you'll already know lots of MRI. You'll know much more than you think. The main views are the same, your 2, 3, and 4 chamber, and then you have your short axis stacks. So this is the quality of MRI. You can see the spatial resolution is much better than echo, but the temporal resolution is not as good as echo. So that's why MRI, echo will always be the first line and gold standard for valves, because you cannot beat the temporal resolution of echo. And this is why MRI is so accurate at quantifying LV and RV function and volumes. Rather than doing a Simpsons and making assumptions, or even a 3D echo where you're tracing, this is what we do in MRI. We slice the ventricle into 10mm slices, and we literally trace end diastole, end systole, mass, and the RV in every single slice at 10mm intervals, and you get a really accurate model of end diastole and end systole, so you can get your volumetric data. And that's why it's the gold standard. So these are some indications. These are some patients I have, and some of the things we do. So have people heard of T1 and T2 mapping and T2 stars? Has anyone heard of that? I'll take that as a yes, because I think that is commonplace now. So these are the things we can look at in MRI. So let's talk about contrast. So contrast, the gadolinium is given to the patient, it washes into the heart and then washes out. If everything's normal, the gadolinium will wash out of the heart and it will not stick to the heart. Gadolinium contrast will stick to basically bad things in the heart, areas of pathology, areas of problem in the myocardium, and then the gadolinium will stick to that area. So when we do our images, we typically do cine images, then we do mapping images, then we do contrast, then we stress the patient if needed, then we do late GADs. And we call it late gadolinium enhancement because it's the last part of the scan. You give the gadolinium contrast, and then you leave it for 10 minutes while you do their imaging, and then you do your gadolinium imaging. Because if things are normal in the myocardium, the gadolinium will wash out. But if there is something abnormal, the gadolinium will stick to it, and even after 10, 20, 30 minutes later, that gadolinium will be stuck to that area, and it will light up like a lighthouse. So I'll show you the next slide first, actually. Actually, I'll go on to this slide, then I'll go back. So this is how contrast works, and this is how gadolinium works. So in a normal patient, when you do your gadolinium images 10 minutes later, the muscle will look like this, it's black. But where you have an abnormality or pathology, what you will then get is the gadolinium will stick to that area. And not only will you be able to say there's actually gadolinium there, you'll be able to work out likely etiologies depending on where the gadolinium is. So if it's subendocardial, that's usually coronary disease. And the reason is the bit that dies is the bit further away from the artery. Because the coronary arteries sit on the outside of the heart, the subendocardium is the bit that gets the least perfusion. So that's why in the ischemic cascade in an MI, you get the subendocardial infarction, then that extends transmurally. So subendocardial enhancement in a regional pattern is coronary disease. If it's full thickness, that's transmural. You can get if you get subendocardial global enhancement, then that is usually seen in amyloidosis, in AL amyloid, when you do the imaging early at about 3 minutes. If it's mid-wall, then that's based in non-ischemic, non-coronary disease. If it's on the outside layer of the heart, that's called subepicardial. That's usually myocarditis, sarcoid, or inflammatory conditions. If it's a thin strip in the mid-wall, that's usually seen in idiopathic non-ischemic DCMs. And you can get something called insertion point fibrosis. The insertion points are where the LV and RV connect together, and you can get a little bit of fibrosis there as a non-specific feature in any condition that causes LV and RV strain, because that's the point where the ventricles are joined together. But if you get very, very prominent insertion point fibrosis, that's quite commonly seen in HOCM, very, very prominent insertion point fibrosis. So these are some examples. So this is an ischemic cardiomyopathy, so a subendocardial infarct. You can see the late GAD. So gadolinium sticks and lights up on late gadolinium imaging. And for the trainees that do imaging, it lowers your T1 value. And low T1 values on T1 weighted inversion recovery images like your late GAD are bright. So that's why you get enhancement for the trainees that are doing MRI, because it lowers your T1 values. Gadolinium sticks to things and lowers T1 values. And T1 values that are low on T1 weighted images are bright. So that's just exclusively for the MRI trainees. I know there may be some here. So here you go, subendocardial infarction, subendocardial late GAD, that's ischemic, DCM, non-ischemic. So you've got mid-wall fibrosis, you've got HOCM here. Myocarditis, you've got subepicardial enhancement, same patient. ARVC, you've got enhancement throughout the right ventricle. Sarcoid is the really tricky one. Sarcoid is the ultimate mimicker. It can mimic anything. But the key features of sarcoid are usually that you get multiple areas of late GAD in a non-ischemic distribution, and you often get basal thinning of the basal septum, first of all. Amyloid is a very interesting one. Amyloid, when it's really bad, AL amyloid is a condition where the whole myocardium is affected. The whole myocardium is infiltrated by amyloid. And in that, what you'll then see is a different situation where no muscle will be black, none of it will be black. Everything will look abnormal and strange because the whole myocardium is affected. So you'll never get any of the bits looking black. They will all look very bizarre and grey and white because the whole myocardium is affected. So that's your late GAD patterns. That's why late gadolinium enhancement is very important. We call it late gadolinium because it's late and it's enhancement. And it's more than just fibrosis and scarring. The distribution can tell you what the pathology is. So I'm going backwards. So these are some indications for MRI. So you've got, so we have T1 and T2 mapping. Mapping is basically, it's called parametric mapping. And this, depending on what your cell is made up of, your myocardial cell, you will get different T1, T2 and T2 star values. T1 values are your replenishment of magnetization as you turn off the radiofrequency pulse. So normal T1 values are about 960 milliseconds. If you have high T1 values, that tells you that there is fibrosis or scar in that myocardial cell. If you have low T1 values, that tells you that there is iron or lipid in that cell. So that's why it's very, very good for your patients with HOCM. Is it HOCM? Is it Fabry's? Is it amyloid? Fabry's is the only condition where you'll get hypertrophy, but with low T1 values. Hokum will normally give you elevated T1 values of around 1100. Amyloid will normally be around 1400. So depending on the presence of T1 elevation, you'll know that there is some extracellular pathology going on in that heart. And you can work out whether it's lipid or iron if it's low, or whether it's sort of scar, fibrosis, and sarcoid if it's high. And that's your T1 mapping, and it's color mapped. So where there's high T1 values, you'll get bright areas. And you can see in this patient, this is someone who has had an infarct, actually, coronary infarct. So you can see there is elevation here in the areas where you've got the scar and edema. And this is quite a unique situation. This is microvascular obstruction. If you have a really bad infarct, you can get microvascular obstruction. This is the CMR version of no reflow. Here, you get no, here you actually get scar, but with a black area inside it. That's not normal. That's even worse than scar. Where you get jet black inside scar, that's called microvascular obstruction. It's jet black because the contrast never even made it into the first place. So MVO is called microvascular obstruction. That's where the microvasculature inside a scar has obliterated, and that will never recover and remodel. So that's T1 mapping, so you can work out what things are made up of. T2 mapping is to look for water. Water increases your T2 values. So where you have high T2 values, that tells you there is edema, that tells you there's an active process, myocarditis, active sarcoid. So this is a patient with myocarditis, and you can see the T1 values, T2 values are high. These are areas of high T2 values, so more than 60 milliseconds. So this is one with acute myocarditis. You can see the scar with myocarditis, and you can see the edema. So you know this is actually acute myocarditis. T2 star is what looks at iron. Iron is paramagnetic. Iron causes your protons to get disordered and just crash into each other. And then that reduces your T2 star values. It's just a number we measure. So if your T2 star values are less than 20 milliseconds, then that tells you there's iron overload. So this is a thalassemia patient. There's two patients here. One has got dark liver. So this is someone with hepatic iron overload, but not cardiac. And this is a patient who doesn't have hepatic iron overload, but actually has cardiac iron overload. This is really black. This almost looks like a late gut image. This is actually just a cine image. The myocardium is so black because it's full of iron. So we can, with T2 star imaging, we can quantify iron. So these are some other indications that are very good for the power of CMR. So excellent for complex congenital disease. So this is a patient with an extracardiac fontan, a TCPC. So you can not only look at the heart, but look at things around the heart. There's no radiation, so you can do serial imaging on these ACHD patients. It's very, very accurate. So I do complex congenital MRI in my hospital. So we do a lot of fontans and the complex sort of TGA type patients, and it's very, very good for congenital heart disease because you see the inside the heart, the extracardiac anatomy. It's no radiation. And because you've got unlimited planes, you can reconstruct things in any way you want. So you can look at things like baffles and conduits really nicely. Very good for valves, valve morphology. You've got a bicuspid aortic valve. And it's excellent for your Minoka patients. When you get your Minoka patient, you know, it could be one of these three pathologies really. And it's very useful to do an MRI. The MRI will tell you exactly what this patient had. And you can work that out depending on the scar. So if it's myocarditis, they'll get scar on the outside, subepicardial. If it's infarct, they'll get scar on the inside. And if it's Takotsubo, they won't get any scar. So this is a patient who has, anyone have an idea what this pathology is, what this patient has, this defect? So this is a patient I scanned last year. So aorta and pulmonary artery, this is the PDA. So this was a PDA, really nicely picked up because you can look at extracardiac anatomy and you can reconstruct things. You can do what we call flow mapping, phase contrast imaging. This is almost like a poor man's version of Doppler imaging, so you can see flow patterns. Very good for Hokum patients looking at fibrosis. So CMR is really powerful. And this is one we published recently, a case report on a guy with ALVC. So a patient, he's an ex-international athlete who came with polymorphic VT and then degenerated into VF. Has lots of scarring in his left ventricle. It was mid-wall, so we know it's non-ischemic. His coronaries were normal. What's going on? Is this sarcoid? Is this myocarditis? What's going on? So then we did T1 mapping and we found uniquely in the area here where he had late GAD, the T1 values were actually very low. And the only condition that would cause that is iron or fat. So this patient actually had fat infiltrating into scar, and he had fat throughout his myocardium. This was actually ALVC, and this patient then had a positive gene test for desmosomal abnormalities. So that the T1 mapping was the only way you could work out what the pathology was here, because you could work out the cellular sort of constitution of that cell. This is stress MRI for those who have asked about it before. So this is adenosine or regadenoson. We're giving a vasodilator. It dilates the normal arteries, but the bad artery can't dilate any further. So it's a steal phenomenon. The good artery steals blood away. This is a normal one where you're giving contrast, goes into the left ventricle and then lights up the myocardium. If it fails to light up an area, you get a perfusion defect, as you can see here. And that's a severe subendocardial defect in the LAD territory in the septum, and this patient had a critical proximal LAD defect. You can do dobutamine CMR as well, but it's vasodilator CMR as a standard. Dobutamine CMR is useful in certain patients, and it's good if you're training in MRI to know how to do a dobutamine CMR in case you're called upon it. You probably do 2 or 3 a year. Dobutamine CMR will be used for a patient really where you want to get viability data. You want to get stress and viability data, where a DSE is really non-diagnostic or an MPI is non-diagnostic, and you're struggling to know about ischemia and viability in that patient. So the dobutamine CMR will give you ischemia and viability and important contractile reserve. That's the key question. Is that muscle going to improve? And if it's a difficult call on viability, is it viable or not? Then the next level on from that is really to look at contractile reserve, and dobutamine CMR will give you all of those things. So it's good to be, when you're training, get a couple of those under your belt, and it's very simple to do. Just think of it as doing a stress echo. So we do the same thing, 10, 20, 30, 40 of dobutamine, and we look at wall motion and perfusion. So I did my PhD was in, and most of my research is in MRI. So this is a slide really to show, I can only base on my work that how powerful MRI is in research. So those who are doing out of program research, if you're doing imaging, you'll probably end up doing some MRI. MRI is extremely reproducible, it's extremely accurate, it's extremely powerful. You've got tissue characterization, and that lends itself really well to research. So my research was looking at, I did the culprit study and I led the CMR sub-study of that. So my research is all in acute, mainly ACS and acute MI work. And we myself and Jerry McCann, we wrote a review about what you for MI assessment of coronary, MRI assessment of patients with MIs. And I'd recommend reading this for the trainees. But it's a very powerful research tool. And we were able to do, you can do MRI strain. MRI does strain very, very accurately. And that we published a paper looking at segmental recovery post-MI. Not all patients with 50% or more enhancement will be non-viable. People always think if there's more than 50% scar, it's non-viable. In the chronic stage, that is, but acutely, you've got to be very careful. Scar size can be overestimated by edema. So we did some strain work looking at sort of predictors of recovery. We looked at sort of stage versus immediate PCI for multivessel disease, second versus third generation antiplatelets. And the power of MRI was its reproducibility and accuracy, and the fact that you can quantify things like infarct size and edema in grams. It's extremely accurate and it's extremely reproducible. And when you have an accurate and reproducible modality, then it's extremely powerful, because it becomes a good surrogate marker and increases the statistical power of that study and brings down the N number that you need. So it's very powerful in research. So these were just some of the papers we published. So the last sort of 10 minutes, I'll go through CT and nuclear. So CT is a more recent development, and you all know how CT works, and you've all probably had some insight into cardiac CT. The main thing really I want to say on this slide is the workhorse for cardiac CT is coronary disease. It's really, really useful for coronary disease, for looking at native coronary disease and working out the cause of chest pain, but also very good at looking at grafts. But it's not all about coronary disease. CT is so much more than coronary artery disease. There's so much structural information in structural CT that you have at your fingertips. It's very good for masses. It's very good for pericardial disease. It's excellent for vascular disease, very good for valves. For TAVIs, it's a prerequisite. It's very good for if any of you are doing mitral valve, catheter mitral valve replacements. It's excellent for doing that. And it's very good for ACHD work as well. Good for Fontans. If you're looking at a patient who may have an occluded Fontan circuit, CT will be the best modality. You can do simultaneous upper and lower limb injections and look at the Fontan circuit. Very good at looking at baffles and conduits. So it's mainly for coronary disease. That's going to be sort of 95% or 90% of the work that you do. But please remember that it is very useful for non-coronary work as well. And it can be the difference between patients getting a diagnosis and not getting a diagnosis for non-coronary work as well. Mainly on an outpatient basis at the moment, but you can do it as an inpatient. And for coronary artery disease, you'll all be familiar with the CTCA, but always remember the triple rule out as well at your disposal. That's a useful test that will look at, which will tell you about coronary artery disease and ACSs, aortic disease and aortic syndromes, but will also give you a PE in the same scan. It's very quick to do, very simple to do. All it is just a CT coronary angiogram with a little bit of extra contrast to provide enough contrast opacification from the pulmonary arteries to the left heart. And it's something that's very useful on your patients with odd chest pain, a bit of a troponin rise, you're not sure whether it's cardiac or not, you're not confident to get them home without doing an inpatient test, you don't want to subject them to an invasive coronary angiogram, triple rule out is perfect for that patient. And there's going to be an explosion in demand for cardiac CT. But cardiac CT, again, is all about capacity. All patients should be getting cardiac CT. The first time is for chest pain. But it depends on the hospital and how many scanners you have and how many sessions you can get. And in our hospital, for example, we don't have much capacity because we've got 1 or 2 scanners that everyone's fighting for. So we don't end up doing as much cardiac CT as I'd like to for coronary disease. So when you choose your modalities, it's all about resources and expertise at your center as well. So this is some example of cardiac coronary artery disease work. So you've got calcium scoring, really powerful prognostic marker. A calcium score of more than 0 is adversely prognostic. So calcium scoring, they've ditched it from the NICE guidelines, the new ones, but I think it should be done because a calcium score, not having a calcium score will not stop you looking at stenosis gradients, grading, but will actually help risk stratify the patient. Because if they've got calcium present, even if the coronaries have no flow limiting lesion, they've got coronary artery disease and they should go on primary prevention. So I would advocate always doing calcium scoring. So on patients with suspected coronary disease. The ones you won't do calcium scoring on are patients with bypasses because you obviously know there'll be lots of calcification, and you wouldn't do it on patients with metal implants like pacemakers or mechanical valves in the heart because it becomes harder to interpret in those cases. So this is showing how well it correlates with invasive angiography. Really accurate, very, very, very sensitive. Specificity is good and it's getting better. So it's very good for accurate diagnosis of coronary disease, but it also is prognostic. And you'll all be familiar with Scott Hart, over 4,000 patients in which CTCA versus standard treatment, at 6 weeks, there was about a 27% reclassification of patients' diagnoses, about a 20% reduction in functional testing and invasive angiography needed. And they had a 1.7-year follow-up, and they had, reduced non-fatal MIs and cardiac deaths as well. So CT does change patients' prognosis. It helps you get the right diagnosis. It helps prevent invasive angiography and functional testing if not needed. And importantly, the calcium scoring and the presence of seeing coronary disease, which you wouldn't see on an invasive angiogram, allows you to provide preventative measures in these patients. On an invasive angiogram, you may just say normal coronaries, but they may well be anything but normal. They may have lots of calcium and lipid and stuff in the walls of the vessel that is sitting there and needs preventing. Very good for grafts, excellent for grafts, and I think where possible you should do a CT before invasive angiography because you can see grafts that are occluded that you then don't need to bother looking for invasive angiography. FFR, CT-FFR is available. This may not be available in all centres. It's still expensive, £630 per patient. Heartflow have got a monopoly. Even after the NICE free period, now they've rolled it out, even with a discount rate, it's £630 or £614 per patient. So you've got to think about, it's very useful. The cost effectiveness is there and it saves downstream testing. So it's got its pros and cons. it's accurate and it is prognostic, but it all depends again on your centre, really. How much CT availability have you got? How many sessions have you got? And what the funding is like. And I think some people asked me to talk about this when I did put this on the WhatsApp. High risk coronary anatomy this is the benefit of CT coronary angiography. It doesn't just show stenosis and calcium, it will show plaque characterization. CT coronary angiography is as good as IVUS and OCT at looking at plaque and looking at coronary artery anatomy and looking at plaque characterization. There are a number of high risk features here, and they're all additive, and they all have about an 8 times relative risk increase of having an acute coronary syndrome for patients that have these. So the presence of positive remodeling. So positive remodeling is where there may not be significant stenosis, but the vessel is getting fatter. And that's because lipid is building up in the walls of the vessel. And you won't see this on a standard invasive angiogram. You might just say mild stenosis, but you won't see a wall that could be potentially full of lipid. So that's a high risk feature. Low attenuation, that means very dark areas of less than 30 Hounsfield. That shows a very lipid rich dense core. Napkin ring sign is a really bad one. That's the presence of it. That's basically when you have a lipid rich fatty core with a very thin fibroadenoma cap that could easily rupture. So you get that feature on a CT. Spotty calcification is high risk. That's actually the most specific for ACSs. And then severe stenosis. So it's not just about the degree of stenosis or the degree of calcification. Whenever you have plaques, we need to talk more about them. This applies to non-calcified plaques, guys. Calcified plaques don't have these high-risk features. The high-risk feature you'll have in a calcified plaque is something called negative remodeling. That's where the whole of the lumen is calcified and the vessel is shrinking, and that will almost always be severe. That's called negative remodeling. But these high-risk plaque features are for non-calcified plaques. So if you have non-calcified plaques, for the reporters, in addition to stenosis grading, please talk about their plaque as well, because that's really important to know. What you do about the patient is really, they're looking at data on what you should do on them. There's more research going on, but the key thing is aggressive risk factor modification if you see any of these high risk features. And it's basically plaque progression. This is what happens. And you can see why it's important in treating the patient. You can go from your initial normal lumen to building up fat in the vessel. And this is the point here where you want to get in there and start them on a statin, aggressive lipid lowering, aggressive lifestyle measurements, because if you don't do that, you won't see these things potentially on an invasive angiogram or on a functional test, and you'll just say normal coronaries or no ischemia, but you'll miss the boat. This is the time to get in there and get preventative measures in and prevent them from going on to the vulnerable plaques which then rupture. So, you know, your plaque characterization is very important. And you can see CT coronary angiography is almost as good as an IVUS. It pretty much shows all the pathology that an IVUS will show. These are just some important sort of other indications of cardiac CT, very quick visual slides. Good for congenital defects, potentially, if you have especially for sinus venosus defects. If you have a patient that can't tolerate a CT, you can do a CMR, but you can see venosus defects on a CMR, but CT is your get out of jail card. Because it's a full volume with contrast, you can reconstruct any part of the heart. You can see your sinus venosus defect here. Very good for aortic valve, aortic root abscesses. You can see the abscess around the aortic valve. You can characterize that. Obviously very good for TAVIs. You get the peripheral vasculature. You need at least 6 millimeter vasculature to get up to the heart. And then you not only look at the vasculature, but you look inside the heart. So when I do my TAVI CTs, I break it up into 3 components. The heart, annular measurement is the key, because that has to be very, very accurate and down to millimeter or sub-millimeter accuracy, so the interventionist can take the right valve off the shelf. The other things we look at are coronary heights. We need to have at least 10 millimeter distance from the annulus to the ostium of the coronaries, because when the old valve leaflets flip open, they could close that off. So that's important to look at. We look at the degree of calcification in and around the valve. That it predicts your risk of things like complete heart block if it's extending into the septum. And we can take more specific measurements depending on whether it's an Edwards or a Cole valve for the way the valve fits. We can also look at the coronary arteries in the same scan. If someone's having a TAVI CT, don't bother doing an invasive angiogram, just get the TAVI CT done, because all you're looking for is severe proximal disease. That's all they're going to fix. So if you don't have severe proximal disease, then you don't need to do an invasive angiogram. If there is potentially severe proximal disease, then obviously then you would do an invasive angiogram before. But a lot of people won't need an invasive angiogram before a TAVI CT. And then there's the peripheral vasculature, the 6 millimeter diameter, and the angulation that you're looking at. And it also we look at other routes. I normally talk about subclavian as well. So if they can't get up the femorals, they can go into subclavian. This is a patient with a transcatheter mitral valve replacement. So I have a patient coming back to me in a month's time who I'm going to plan for a TMVR. So the things we look at are the annular size, but the most important thing is we look at the LVOT, because when you put a TMVR in, the old anterior mitral valve leaflet will flip open and stay open, and it will cause an LVOTO. You'll create a neo-LVOTO. With the valve sitting here, and the old AMVL and the AMVL especially coming out here. So CT allows you to predict the annular size, which is important, but most importantly, you're looking at the LVOT. You're predicting what the new LVOT will look like. With the AMVL fixed here, looking at the aortoanseptal angulation, the basal septal hypertrophy to determine whether it's safe to put a TMVR in, because you will always get some degree of LVOTO after it. This is one area that I always try to promote, really. These are some cases that I published a few years ago. This CT is brilliant for prosthetic valves. It really is fantastic. It's a fantastic adjunct to TOE. You can beautifully see mechanical valve leaflets on a CT. So if you have patients who you can't see valve leaflets, you're thinking about valve obstruction, you can't see the leaflets clearly on a TTE or a TOE, you're getting lots of shielding and reverberation, do a cardiac CT. Gated cardiac CT, you'll beautifully see the leaflets. This was a guy who had a AVR, a young guy, whose velocities were progressively increasing and his Vmax went to 3.7 meters a second, and he came in with a dizzy episode. They were thinking about replacing the valve, thinking it may be pannus or thrombus. The valve was actually moving beautifully. What actually happened is his stroke volume had increased after they put a CRT in, and that was the reason for the increased stroke volume in Vmax, and the leaflets were actually intact. So very nice at looking at leaflet motion, and for characterization of when you have obstructed leaflets, is it thrombus or pannus? CT is really the best. So pannus can be seen on echo as a bright area, but it can be difficult when you've got shielding from the valve. CT is fantastic. So pannus is a ring that grows underneath the showing ring and grows inwards. And you can tissue characterize on CT. It's called a Hounsfield unit. It's basically how bright it is, how much contrast is taken up. Pannus is normally dark gray and has a Hounsfield unit of more than 100 units or more than 130, whereas thrombus will be very low and less than 100 or 130 Hounsfield units. So you can work out whether it's pannus or thrombus, because if it's thrombus, you just anticoagulate the patient. If it's pannus, then you've obviously got to redo the valve. So this was a patient I scanned a few years ago who had a biological valve, severe obstruction. They were thinking about a valve in valve TAVI. We CT'd him and actually found there was hardly any pannus. It was mainly just thrombus sitting on there. So we anticoagulated the patient, got rid of the thrombus, and the pannus remained but caused no obstruction, saved him having an operation. These are one or two more. So multimodality cardiac imaging is really the way forward, especially for complex cases. Just echo, just MRI, and just CT is not going to be enough. It really needs to be an interplay between modalities now. And this is a case that I published with last year on a patient with, which was deemed with inoperable mitral valve calcification from previous chest radiotherapy. And this patient ended up having a double TMVR and a TAVI at the same time. And this was a beautiful interplay of 3D TOE and CT, where they both approximate each other beautifully. So this could work out the degree of calcification around the valve to work out whether they could get a new valve in, could you stitch into the valve? And we could get very accurate dimensions of the valve for the TMVR and TAVI. So there's going to be a lot more interplay of modalities working together in the same patient. And this was just, I wanted to show this was a question raised on WhatsApp a few weeks ago in this thread, a young guy with an out of hospital cardiac arrest and something about looking at the coronaries. In these young patients with out of hospital cardiac arrest, if they haven't got ST elevation, you don't need to do an invasive angiogram, do a CT. You get so much more information with a CT. Not only do you see stenosis of the vessel, but you'll also be able to see Not, someone's someone's off mute and there's music in the background. Thank you. I'm almost coming to an end. So this is the other benefit of CT. Not only do you get coronary artery stenosis, not only do you get plaque characterization, but you get a lot of extra cardiac anatomy. You can look at the pulmonary arteries and you can look at exactly where the origins of the arteries are. So for the young patients with cardiac arrest, don't do an invasive angiogram. Absolutely not. Go for a CT coronary angiogram. You'll look for anomalous coronary arteries nicely, because that's the real question. Have they got a malignant intra-arterial or intramyocardial coronary artery course? You'll get a lovely image of that on a CT. Give a bit more contrast and do a triple rule out in the same patient. You can rule out a PE in the same patient as well. And then you can look at coronary artery disease. And this was a patient that we published who actually was a 29-year-old guy who had a cardiac arrest on a treadmill. And interestingly, he did have critical LAD disease. So he ended up having a vulnerable plaque here, a non-calcified plaque. That's the lesion. That's a bit of positive remodeling. It's become fatter, and you can see a very hypo-intense course. So this guy had severe proximal LAD disease, which was a vulnerable plaque, which then we cathed and PCI'd. So it is good for plaque disease, which can happen in young patients, but it's the other things, the anomalous coronary arteries and the pulmonary artery, that can be seen in the same scan. And finally, I'm just going to have 2 slides on nuclear. I'm not a nuclear practitioner, but it is a great modality, and MPI is good if you like that and you have good practitioners in your centre. But I'll talk mainly about the other ones, the other uses of nuclear, which are the key ones and the ones where you definitely need nuclear. So we all know about its use in ischemia, stress, adenosine or regadenoson stress MPS. But these are the other things that we have at nuclear at our disposal for, where it's really useful. Everyone knows about ischemia, but these are the other ones where you use nuclear. It's really powerful. It's a great test, and it will give you answers that no other test can. So where you have a patient who has no diagnostic images, they're too big to put in an MRI, or they have a contraindication, they're too big to scan with an echo, and you need to know their LV and RV function, go for a MUGA, a multi-gated analysis. That will give you an accurate LV and RV volumes, LV and RV ejection fraction. You won't get anything else, but it will still be the difference between knowing if someone's got heart failure or not, and knowing if it's systolic or diastolic. White cell and FDG PET, so these are very good for looking at inflammation and infection in the heart. Radio-labeled cells will light up in those areas. Very good for 2 main conditions. So sarcoid. With sarcoid and cardiac sarcoid, the question after you've diagnosed it on MRI usually will be, is it active or is it quiescent? MRI will give you a good answer because you can do edema imaging to look for an active sarcoid, but MRI edema imaging can sometimes miss potentially inflammation in the heart. So MRI and PET-CT are very good working in combination with each other for cardiac sarcoid. To diagnose a cardiac sarcoid on MRI, get an idea if it's acute or not on MRI, and then really confirm the acute or not status on PET-CT. So they work very well together. And the other area is infection. If you're suspecting endocarditis, especially when there's prosthetic material in the heart, and your TOE and your echo shows lots of artifact, lots of reverberation, and you need to know what to do. Do I take that pacemaker out? Do I send that patient to surgery for their aortic root? Do a PET-CT. It will light up areas that have got infection. It's very good for prosthetic material or when echo doesn't give the answer. Gallium used to be used for sarcoid specifically, but now we mainly use FDG. And the last one is DPD. When you have an amyloid patient and you're wondering whether it's AL or ATTR, it's very important. AL amyloid will require conventional chemotherapy and have a much worse prognosis. ATTR will usually be things like tafamidis or even liver transplantation if it's hereditary, not wild type. And you can tell the different, MRI gives you an idea. Amyloid is normally throughout the myocardium. TTR is usually worse at the base and better at the apex. You get a base to apex gradient. But if you're not sure, DPD. DPD is a nuclear scan and that binds to TTR. You may not have, there's quite a shortage of DPD around the world, so you can actually do a standard isotope by bone scan here to look for TTR. So here, just the last slide with some images. This is a MUGA scan, where you basically get, it's almost like a contrast echo. You get EDV, ESV, and LVF. This is a MPI where you've got rest imaging here and stress. You can see an anterior wall and septum is not lighting up, so it's an LAD defect. This is a patient who's had a mitral valve annuloplasty, an aortic valve replacement, suspected endocarditis. It's lighting up. And this is a patient with sarcoid, who on MRI you can see scarring. And the edema imaging was a bit inconclusive. So then we did a PET and it lights up. So that shows you there is sarcoid and it's active. And this is your TTR patient with a heart lighting up. It's actually black, but it's lighting up. So that's the end of the talk. I was just asked by some of the guys to do 5 minutes at the end about training. There was a whole thread about cardiac CT today. So I thought I'll just do three last slides on accreditation. Any questions before I do these last 3 slides about anything I've talked about? I'll be done in 5 minutes. Anyone want to ask me anything about TOE, 3D echo, CT, CMR, nuclear?
I think, Jamal, if you just finish the slides, then we'll take questions at the end if there's anything else.
So echo training, really, I think if you want to be a cardiac imager and you want to train in echo, you've got to do your BSc TT, you've got to do your BSc TOE. Stress echo accreditation is there. Hardly anyone goes for it because I think it's a bit of an unrealistic ask. So for stress echo accreditation, the issue is you need to have a logbook of 200 patients where you scan and report them yourself, which is achievable, but the main problem is they want at least 40 positive studies, and that's the problem. That's assuming that 20% of your studies are going to be positive. So for that reason, there's only about 3 or 4 people in the country who are accredited in stress echo, and they're usually the people that are doing 3 or 4 lists per week themselves, and then who will acquire 1,000 cases, and from those 1,000 cases, then they'll get 40 positives. There are a couple of people around the country, mainly in Wythenshawe, the main ones. So for imaging trainees who do echo as one of their 2 credits, you've got to do advanced TT and advanced TOE and TOE, and you've got to do stress. You've got to learn those 3 modalities as a senior imaging trainee. You absolutely have to have BSc TT accreditation, and I would say anyone who wants to practice TOE as a consultant should have TOE accreditation, and any trainees that are doing advanced imaging absolutely have to have TOE as BSc. You will not CCT without that. Stress echo, just get good at it. Learn how to do coronary artery disease stress echo, and if you have exposure to an exercise bike, really learn how to do some non-ischemic stress echo. It's really useful. CMR, so for CMR training, level 2 and level 3. Level 2 and level 3 are what you need to be a consultant basically and practice these. So level 2 means you can work as a consultant in MRI and report it independently. Level 3 means you can actually train other people in it and you can lead an MRI service. So level 1 generally requires you to sit the EACVI written exam on MRI. That's done 2 or 3 times a year. You have to pass that, and then you need to provide a logbook of 150 cases where you're the primary reporter yourself. And you need to have a case mix of a different range of pathology, and you have to collect that over a 2-year period. And you also need things like ALS, and you need about 20 hours of CME, and you put that all together and submit that. And then that's what you need for level 2. Level 3 is where you need 300 cases, and I'm really pleased about the peer review. So I sit on the EACVI CMR exam board, and we are all pushing to make it harder. Level 3 CMR is just too easy. 300 cases is really quite easy to get for level 3, and just because someone has done 300 CMR cases does not make them an expert in CMR. 300 cases can be done in a year with a limited, maybe 20 or 30 of each type of pathology. So they're going to make level 3 harder, and I'm really pleased about that. So what they've done now is they've kept it at 300 and the exam, but you have to have 1 item of peer review. They're bringing it more in line with level 3 CT. So if you want to get level 3 CMR, you need to have 1 item of peer review, either 3 publications in CMR, or you have to teach on 2 CMR courses, or you have to be an invited speaker at 2 conferences to give lectures in CMR, or you have to present original data in the form of an oral presentation at a CMR conference. Because too many people have CMR level 3 at the moment who are not experts in CMR. So this is a really good thing. And what I was saying in terms of training in CMR, please don't just report. And that's the one problem at the moment with CMR accreditation. It doesn't work out whether you can actually scan patients and supervise lists, because all you have to provide is reports. It has no OSCE or no practical way of knowing whether you can supervise lists. So when you do CMR, you need to be able to run the machine, you need to be able to optimize the machine, change the settings, reduce breath hold times, get around arrhythmias. You're the one who is going to advise the radiographer on what to do and how to optimize image quality and plan complex imaging. So when you're training an MRI, please be in the control room, work with the radiographer, optimize images, watch every image as it comes out, change the breath hold times, change the gating, make sure every single scan that you do is diagnostic and there should be no blurring. So you'll only learn that from being in the room. And that's one of the things that doesn't always happen. There's a culture of trainees just reporting and spending very little time in the scan room. And when you become consultants, then you lose that confidence in actually being able to scan patients yourself and setting up a service yourself and advising radiographers on what to do. And then you see blurry images. People with ventricular bigeminy and AF, they don't need to have blurry images. You can get around those things. You can get breath hold times down to 3.5 seconds and still be very, very high quality in your poor breath holder. So this is mainly aimed at those training and MRI. Guys, please spend lots of time in the control room, learn to scan and learn to supervise studies. Supervising doesn't just mean sitting in the control room reporting, it means working with the radiographer to make sure every single image that is produced is high quality. And they'll love you for that. The radiographers really like that interaction. So that's CMR. And then CT finally, there are two types. There's SCCT and BSCI, the Society of Cardiac Computed Tomography or British Society of Cardiac Imaging, Cardiovascular Imaging. So level 2 means that you can practice as a consultant, independently practice and have lists. And level 3 is the same. It means you can lead a service and train other people. So level 2 is probably what 95% of people that do cardiac CT have, and it's a very good benchmark, and you can run cardiac CT to a very high level and produce great cardiac CT and a great service. So that's what most people will go for. There's two ways to get level 2 CT accreditation. One is with a course and one is actually doing it. The course will be a 1-week course generally in which you have intensive lectures, 7-8 hours. There are days like 10 hours long, 4-5 hours of lectures a day, and then 4-5 hours of doing cases together as a group. And you'll cover 150 cases over the week, and that will cover your requirement for level 2. It's a really good way of getting intense theory and knowledge and a background into CT and learning how to do basic insight into reporting by really top quality CT people. All the level 2 CT cases, courses are brilliant. They're all run by really good people who are very well respected and will provide brilliant training. So they're a really good resource for that reason. But level 2 cardiac CT, in my opinion, it's not enough. If you go on a level 2 cardiac CT course, it doesn't mean you can then go out and start doing cardiac CT. It's like saying, because you're only doing 1 week, you're not seeing the patients being scanned, you're not scanning them, you're not optimizing the images, and you're not reporting the scan in full. You may just be spending like 5 minutes on a scan together as a group. So it's very, very good at what it does to give you that insight and intense primer and knowledge and give you a bit of an insight on how to report things. So it's fantastic for what, it depends on what you want to use it for. So if that's what you want, it's really good, go for it. They're fantastic. But then what you need to do is then do lots of cardiac CT under someone's supervision and have your reports checked and signed off. That's the proper way to learn cardiac CT if you have that availability. And again, with cardiac CT, guys, it's not just about reporting. You need to be in the control room. You need to be able to acquire the images yourself, plan the images yourself, sort the gating out and make sure your patients have good quality imaging. Otherwise, you'll be purely dependent at the mercy of the radiographers who may have different levels of expertise. So level 2 you can do from a course. And the other way to do level 2 CT is actually train in CT, because if you train in CT properly, you don't need to go on a course. If you do 150 cases from start to finish, where you're in the room watching the patient being scanned and helping with the acquisition, or maybe even for those 150, even if you're in the room for say 75 of them, you'll get an idea, you'll get a good idea of scanning. Then you report the whole study in full yourself and get it signed off by someone else. That will be like proper level 2. That will be where you've done 150 cases yourself. And that will be a much better situation to be in. because by the time you're let loose as a consultant, you'll have actually scanned and reported 150 cases minimum yourself from start to finish. If you just do the course and you don't do any cardiac CT, you'll forget everything you learned in about 1 week or 2 weeks, and it'll be basically like you've been on a course for no reason. So the course is brilliant, but it needs to be an adjunct to having proper exposure and proper training. And then for those who want to do level 3, so level 3 is harder to get. There's not many people with level 3 because there are a couple of obstacles in it. They used to be the same for BSCI and SCCT, and what they want is peer recognition. What they're asking is you need to show that you've done research in CT and published in it, and that you are training other people in CT, and you're involved in development of CT in your country and development of CT training in your region or your country. So what they will want is SCCT have increased to SCT have increased from 150 to 250 and 300 to 450. But it's this peer recognition. So SCCT want at least 3 publications, or that you're a trainer on 2 level 2 courses, or that you lead a training program or fellowship in your region. And what they've done now is they want you to be level 2 or 3 in MRI or echo as well. So they're basically saying we're only going to give level 3 cardiac CT to multimodality cardiac imagers. BSCI is still the same, but they've made it a little bit harder as well. So they want the peer recognition, 300 cases plus 3 or more publications. This can't be case reports. It's going to be 3 or more original publications, or be on a national or international CT society, or you can have 2 of the following, either a PhD or MD in cardiac CT, or that you are the lead for cardiac CT or lead for cardiac CT training in your hospital. So they want evidence of research and training other people on formal level 2 courses, or being a training program director or fellowship trainer. And this is what BSCI have done. And I think this is the best thing I've seen from any change. SCCT have increased to 450, which is good, but this is even better. The fact that BSCI want you to be in the room, supervising, fully controlling the scan for all 300 patients, that's the best thing I've seen, because that turns you from someone who is a CT reporter into a true CT practitioner who will get good images and a good report. So I'm really glad they've done that for BSCI. I think that's a really good thing to do. So level 2 can be obtained off a course. Level 2 can be obtained if you're a CT trainee, but level 3 can only be obtained with those extra things, and level 3 can only be obtained after you become a consultant, because they want evidence of board certification as a consultant that you're the lead for cardiac CT in your hospital. You can go directly to level 3 for SCCT. BSCI don't like people going directly to level 3. They want you to have level 2 and then upgrade to level 3. But if you contact them before, they can potentially allow straight to level 3. So conclusions are as follows. I'll let you have a look at them. I won't read them out really, but it's basically you've got lots of cardiac imaging at your disposal in every hospital. You've all got great cardiac imaging departments, really good cardiac images in your hospital, great physiologists, radiographers, and your cardiac images are ready to really serve you guys. And there's so much more out there at your fingertips than you may potentially be aware of. And really just ask for these tests, and this imaging is really the way forward. And I think training in imaging has to be absolutely formal, dedicated, and accredited as well. So I went over my time a little bit. I apologize for that, but I hope that was useful, guys.
Thank you so much, Jamal. Yeah, I'm just slightly worried that we have overrun by 20 minutes. So, Essen and Rahil, if you guys were keeping track of questions, if there's something else to do, brilliant talk, no doubt. I was in and out occasionally, but overall, really good. I'll leave it for the trainees. I think this is more for the trainees. If I can ask one thing, Jamal,
Yeah.
do you want to stop sharing the slides so people can see you?
Sorry?
Do you want to stop sharing the slide?
Oh, yes. Yeah, I'm just trying to work out how to do that. Yeah.
Yeah, brilliant. You can turn your video on if you want.
Yeah.
Only one question, if I may want to ask, you may be tired after a long talk. From the trainees' perspective, given the fact that the last 12 months, 18 months have been really tough, especially for ST3, ST4, just to get into the echo room, because a lot of the echoes have been delayed, deferred, lists have been cancelled. What one tip can you give them that they can do in the next 6 months to catch up? After that, I'm going to leave for the trainees to ask any further questions. I'll leave it to Rahil and Essen to take it further.
So that's about echo, isn't it, Saqib, you're asking?
Yes, in general, but maybe other things as well. Yeah.
Okay, so first of all, I think it's a really good point, and it's nice for you to say that, because it shows that you're sympathetic towards the trainees. And the trainees out there, guys, we as consultants, myself, Saqib, all the other consultants in this forum, we know how difficult it is for you guys. COVID came along and no one expected it, and it's affected everything. It's affected services, but it's also affected training and the opportunities that you have. And we're completely sympathetic to that. We didn't have that challenge when we were here. So what I want you all to know is that your consultants, and importantly the training program directors, we all know about this, and we completely are on your side, and we're here to support you. And we don't want you to panic about not getting numbers or finding it hard to get numbers. There are ways around this. So please don't panic, and just please know that your consultants and the leads for imaging are on your side. Because we know no matter how hard you work, you may not get the numbers that you used to because lists are cancelled. So with regards to echo, elective lists will be cut because of COVID and distancing and so on and so forth, which makes it harder to get your numbers. So BSc are going to give everyone a 1-year extension. So with regards to the extension, everyone will get a 12-month extension on TET accreditation times anyway. If you have had to have periods where you're shielding, please let the BSc know, let them know early. You can get even more time then. If you want to, the next thing is about how to be clever and get your numbers. So this is what I tell my registrars that often panic about numbers and then have logbooks that are incompletely filled. And I wish they'd done this from the start, really. Your transthoracic outpatient lists are not your only way of getting your 250 cases. You've got to be clever and maximize every opportunity to get cases. So not only do your outpatient list, but your on-call echoes are the keys, guys. When you're on call and you're asked to do an echo, you can either do a target echo for 10 minutes, take the handheld probe or take a machine with you, do a quick echo, do a quick report, an informal report, and all you've done is provided an echo, and you've provided a little bit of service provision to the hospital, but you've gained nothing out of it. Every time you ever get asked to do an echo on call, spend 10 minutes longer. It takes 10 minutes longer to do an echo in full than it does to do a target. You still have to bring the machine over. So when you're on call, guys, every single echo you do, please do it as a full study. Do it in full, report it in full to BSE standards. Not only will that give better treatment and diagnosis for the patient, but be selfish. You walk away from that actually having one more case for your logbook. Think about yourselves. Every time you do an echo, don't just think about the hospital and service provision. Ask yourself, what am I going to get out of this? So every echo that you ever do, you can turn that into a logbook case by spending 10 minutes longer, scanning in full and reporting it in full. And by doing that alone, honestly, you will get 60, 70, 80, 100 cases in a year just from your on-calls. And you'll get a minimum of 50 or 60. And if you do that over 2-3 years, that's 150 cases just when you're on call. That can be the majority of your 250 cases at logbook. So on call is the key. That's your golden ticket to get lots and lots of extra numbers for the same amount of work that you're doing. So that's what I would say for echo. For transesophageal echo, that's harder because they're really getting cut because they're an AGP, and TOE numbers are coming down anyway because it's invasive and people are doing more CMR and CT. So with TOE, if you want to get more TOE numbers, speak to the surgeons, join them at the start when they're doing the induction phase. You can have 10-15 minutes to do an echo then. And the other thing is a simulator. If you have access to the HeartWorks simulator, please use that if you have it in your region. And that'll be a way to get more cases. And it'll mean that if you spend time on that, even if you've done a small number of TOEs on patients, you'll be so much better because you can practice those pulmonary veins, you can practice getting those transgastric views and aortic Dopplers to your heart's content on the simulator and spend as long as you want. And that will mean that the first 30, 40, 50 TOEs where you're really struggling and finding it hard, you can just do that bit on a simulator in your own time. So that's what I would say for TOE. For CMR, yeah, it's a little bit harder, but there are still ways for CMR, guys. So with CMR numbers, remember that you are allowed to re-report cases that have been done previously if you report them blindly. So what I've done for my 2 CMR trainees is I produced a database of all the cases I've done since I started at UHCW. So we've got about 700-800 cases. I've got the names and number of the patient and the pathology. And my trainees, if the lists are cancelled, if my list is off because I'm on annual leave, for example, they can dip into that database and re-report previous studies, and they can count towards the 300 cases. And so in your hospital, if you're struggling for numbers generally, or struggling for certain pathologies like pericardial and masses, for example, ask your consultants, look, have you got any previous really nice pericardial or mass cases? Because you are allowed to re-report those blindly and then report them in full, and then sit down with your trainer and go through your images and your contours in full. So you can get numbers that way as well. And for CMR, at our last committee meeting, they were going to extend the deadline for logbooks from 2 years to 3 years. But I don't think you need that. I think if you have access to a database of cases at your hospital, if you're really struggling with numbers and your lists are cancelled, rather than sitting there twiddling your thumbs and doing other things, re-report previous studies with good pathology, because that is the same as doing a report on a patient that's just been scanned. I know you'll miss out on the scanning aspect, and I'm a real stickler, and I've got almost an obsession about people learning how to scan and optimize studies and being in the room. But if you have no lists, it's a really good way of doing reports and getting pathology for your logbooks.
Thanks, Jamal. Hassan and Rahil, do you have any list of questions? And try and wrap up in 10 minutes if you can.
I will let Hassan take the questions.
Yes, hi. So there are a few questions in the chat. I think quite a few from Dr. Nishtar. The first one he's asked is, what's your sedation protocol for TOE?
Okay, very good question. So my default is no sedation. The reason for doing no sedation is, number one, most patients, if you talk them through it and reassure them, don't actually need sedation. If you do a very careful tube intubation in a gentle way, they won't need intubation, the vast majority. The other benefit of not doing sedation is they can walk out from the TOE and go home straight away. So you don't have to have as many recovery beds and day case beds. And the third and most important thing is sedation will affect the accuracy of your TOE. If you are looking for mitral or aortic valve regurgitation, if you drop the systolic blood pressure with midazolam by anything more than 20 to 30 millimeters of mercury, that is easily enough to drop the grade from severe to moderate or moderate to mild, and you could potentially underestimate the amount of MR. So for MR and AR cases, you definitely want to avoid sedation at all costs, because you can underestimate. The preload drops with your midazolam, drops your preload, it drops your systolic blood pressure, and it only takes 20 millimeters of mercury to potentially drop your MR grade by 1. If you have that situation, then what you need to do is assess the MR and then reassess it right at the end of the TOE as you come out when the sedation's worn off. So that's my policy. I don't give sedation unless they need it. If they do, then absolutely I'll give sedation. And I will give midazolam up to 5 milligrams and fentanyl up to 100 micrograms. And the key with sedation is about patients and the environment of the room. Nice, dark room, cover the patient's eyes, nice and quiet in the room. That is a really important thing. And then after you give midazolam, some people have a habit of just pumping more and more in. Give 2 milligrams and be patient. Walk away from the machine and give the patient 2 or 3 minutes. And that time is often enough for the midazolam to kick in. Quiet room, silent room, no one talking, dark lights, 2 or 3 minutes, and that is enough for that 2 or 3 milligrams of midazolam to work, rather than giving more and more, and then you disinhibit the patient after about 5 milligrams. So that's the sort of bit of a protracted answer on sedation.
Thank you. The other question from Dr. Nishtar was, if you can comment on the use of AI on CMR quantitative perfusion.
Okay, so AI is great. AI is going to be really revolutionizing CT and MR especially, but also echo. So AI is where it's called machine learning, where you've got millions and millions and millions of data sets that have been analyzed and fed into big databases. So they can provide almost automated analysis. So the thing with analysis is always accuracy and reproducibility. And if you're manually drawing things and contouring things, there will always be that intra-observer variability and that test between two people or the same person. And that will always be there, and it will affect accuracy to some extent, and it will make learning curves longer and harder. It's like the old school way of doing things. It's good to learn that way. It's the most important way. But now we have AI. AI will speed up reporting, because instead of you drawing contours yourself, you will click a button and the machine will draw the contours for you. And and I'm going to say the word theoretical quite with a lot of emphasis. The theoretical benefit of that is Number one, it will speed up reporting because the contours are drawn by the machine very quickly. Number two is they may be more accurate than your eye, especially for CT. And number three is they could be more reproducible because you're not manually drawing them yourself. So that's the theoretical benefit, and that will happen with time. As the machine learning gets better and these big databases get better, that's what will happen in time. But the problem at the moment for certain things is it's in a primitive stage. So if you try to do CMR, for example, on CVI42, that's the commonest type, the AI is very good for flow maps, but it's not as good for ventricular analysis, because when you contour the ventricles with the automated analysis, you'll find that it still doesn't track it that well, and you still have to do some manual contouring, which ends up taking longer than it did to manually do it in the first place. So the theoretical benefits are there, and they will come over time as AI gets better. But different modalities are at different stages in that, but they're the benefits of it. In terms of what I would say it's prime time and ready for at the moment will be auto strain for echo and flow maps for CMR. But the big one that everyone wants it to be there for is ventricular contouring for MRI, because that's the big quantification. And I'm not sure if it's ready yet, because I found that every time I do it, I still have to tweak it. So that's the benefits, but it will get better and better exponentially with time. And it will get to a point where it'll be even more accurate and faster than the human can ever be.
Okay, thank you very much for that. A few questions from Dr. Sheikh. First one is there any restriction to doing MRI after PCI?
Absolutely not. So my research was looking at infarct size after PCI. You can put someone in an MRI scanner 1 second after doing a PCI, literally 1 second. There are actually hybrid cath labs in this country which have MRI and X-ray fluoroscopy and angiography on the same table. So there is no stents can go into an MRI scanner immediately. Pacing devices and any other sort of metal implants have to wait 6 weeks. Because they can move in the first 6 weeks. But stents, no issues whatsoever. The only stents where you may have an issue are some of the EVAR and TVARs, because they're very big, and then you need to look at them individually to see if they're safe. And the sort of gold standard Bible of some kind you could refer it to is the website called MRIsafety.com. If you're ever not sure about a device, whether it's MRI safe or not, please go onto MRIsafety.com. And that'll tell you whether it's safe or not and at what magnetic strength. But coronary artery stents immediately can go into an MRI scanner.
Second question from him is about myocarditis, and he's phrased it as in CMR, how long changes lasted in myocarditis? I think he's trying to ask is when is the ideal time, I guess, to do CMR in myocarditis?
That's a really good question. So it's all about edema. So with MRI, you see edema, which is acute inflammation. Edema will not last forever, because edema just means there's water there. It's like when you get a stinging nettle that stings your hand, it swells up. That's edema. So edema is a sign of acute injury. It will tell you something acute's happened. That could be myocarditis, it could be an infarct, it could be anything. Edema doesn't last forever. So for myocarditis, edema will be present for up to around 4 weeks. And for infarcts, edema will be present for up to potentially 6 to 8 weeks. But the quicker you scan them, the better, because the edema will have maximum chance of being there. The longer you leave it, the less time. If you have a Minoka, ideally you want to scan them as an inpatient. But if you can't, I think within 2 weeks is fine, and within 4 weeks is an absolute push. So with myocarditis, because we have 3 criteria called the Late Louise criteria, and one of them is edema. You need 2 out of the 3. So you want to maximize your chances of edema. So inpatient ideally, or if outpatient, 2 week, but no more than 4 week, because you won't get edema at 4 weeks. But that doesn't mean you won't be able to diagnose myocarditis. Even if the edema's gone, the pattern of scarring will still give you the answer potentially, because if the scarring is on the outside of the heart, subepicardially, and the picture was one of myocarditis, you'll still be able to retrospectively diagnose it. But for acute myocarditis, yeah, earlier the better, maximum 4 weeks.
Okay, question from Heather. Any age cutoff for reliability of CT coronaries, considering calcification as a problem?
Okay, good question. So it's the age isn't the issue, it's the degree of calcification. So, but in theory, the older the patient, the more likely you will be to have calcium. I wouldn't give an age cutoff. I've seen lots of elderly patients that don't have much calcium at all, and younger patients that can have lots of calcification. In terms of CTs, I don't have an age cutoff, to be honest. would use it in first line in everyone. I know the risk is higher of calcification, but again, the calcification being there doesn't preclude you to giving contrast. Some centres say if the calcium score is more than 400, we won't proceed to coronary CT contrast because there'll be too much contrast and give too much blooming. That's not the case as well. It's not just about the amount of calcium, it's about where it's packed. If you have a calcium score of 600, but it's scattered in different areas, you'll still be able to threshold and window that out. If you've got a calcium score of 300, but it's one big fat lump in the proximal LAD, then you'll never be able to analyze the LAD segment. So age, I don't think should be used. And then when you see calcification, if you're scanning the patients, it shouldn't just be on the calcium score. Also think about where it is and how densely packed it is in that area. So I don't have an age cutoff.
Sure. A question from Sophia. Can you use the same cases from level 2, or do you need for CT and CMR accreditation? Can you use the same cases from level 2, or do you need new 450 or 300 cases for CT or MRI level 3?
Okay, so good question. So for CT, for level 2, you obviously have your let's go with BSCI because it's the lower numbers. So you would for level 2, you get your 150 CT cases. If you want to do level 3, then you can upgrade with just the extra number. So you're not allowed to use this. You don't need to submit 300 from scratch. So if you wanted to go an upgrade from level 2 to level 3, say for SCCT level 3. So you would go from 250 to 450, you would just provide an extra 200 cases. So once you've got your level 2 accreditation, if you want to upgrade to level 3, you just have to provide the extra cases. You don't have to provide the whole number. That applies for CT and CMR.
Okay, thank you for that. Question from Hamza. Is 4D flow CMR prospectively becoming a hallmark modality for diastolic heart failure, especially in patients with pulmonary hypertension?
So that is 4D flow becoming, sorry, if you can repeat that. Sorry, I didn't catch that.
Sorry, 4D flow CMR prospectively becoming a hallmark modality for diastolic heart failure, especially in patients with pulmonary hypertension.
I'll be honest, I don't know the answer to that. I can find out for Hamza and let him know. 4D flow is a little bit like strain was 10 years ago. I think that 4D flow is still mainly a research thing. 4D flow is expensive to do. It requires expensive post-processing software. And what you'll get is nice visual images with multiple colors of flow. And the analysis from it is very useful as well. But it's really for certain cases, probably the aortic pathologies, bicuspid aortic valves and ACHD patients. It's good for looking at flow patterns, which can help with diagnosis. In diastolic dysfunction, I don't know. I don't know about that. I can find out from him. If someone can email me that question, I'll find out from Hamza. I don't personally practice 4D flow because we haven't got the finances to have it at our hospital. And even if we did, I'd probably want to spend it on something more applicable on a clinical basis. So I'll find that out from him. But for those who are not familiar with 4D flow, it looks at directions and mapping and velocity of flow in different structures. So it can be quantified as well. But that is mainly a research thing. It's not really clinically prime time except for congenital heart disease and aortic disease. And I don't use it. And I even if I had it, it would make probably no difference to my diagnoses or reports at the moment. So I think it's not ready for prime time yet. If you've got it and you can get it in your hospital, then by all means start using it and get used to it. But I don't think it's at the stage where it's necessary or makes a big impact on patients at the moment.
Okay, last question. Any recommendations for center for post-CCT CMR fellowship?
Okay. For post-CCT CMR fellowship, so is that someone who hasn't practiced in CMR as a trainee and then wants to do a CMR fellowship to learn CMR from scratch? Is that the question if the person's here in the group?
It was asked by Westy 3331.
Okay, so in terms of, so I'm presuming if someone says post-CCT CMR fellowship, that would either mean someone who didn't do CMR as a trainee, but wants to learn it as an extra thing, or someone who has done it as a trainee, got level 2 or level 3, but wants to get really good at it. They would be the two situations to do it in. Around the world, I would say there's lots of good centres around the world. Canada's good. if you want to go abroad for CT and CMR. Germany's good, Holland is very good. And within the UK, if you wanted to do a post-CCT fellowship, you can do it anywhere really where there's a good CMR service. So most of the tertiary cardiology centres will have good CMR services, but the ones that are very high volume, because you don't want to be fighting for numbers with the trainees as well, that's the issue. So if you want to do post-CCT fellowship, you want to go somewhere where there's lots and lots and lots of numbers, somewhere where they have 8, 10, 12 lists per week, where they have their own scanner, because you don't want to be fighting for their own numbered trainees for numbers, because they will always get priority. So the really big centres where they do that sort of volume will be that are well known. Brompton's always the well known one. They have like 3 or 4 scanners. If you do it at the Brompton, it's very famous. You'll get lots and lots of numbers, but you won't get paid, because Brompton have so many people wanting to do CMR fellowships there from abroad, from the Middle East and Japan, that pay the Brompton. So if you want a fancy name and lots of numbers, and Brompton is a place to go, you must remember you won't get paid for that. But if you want to go to other centres in the UK, the London hospitals are all good, like Barts and London Heart. In the Midlands area, I can't offer one at the moment because we don't have many sessions on our scanner, because we only have one scanner for MRI that can be used for cardiac. I'm fighting with all the non-cardiac people for time, and we only have 5 lists per week, so I can't take anyone for a post-CCT fellowship at the moment. If anyone wants to look at one in the Midlands, probably Stoke or QE could, because they have 10 to 12 sessions a week. Stoke is good, but the problem is they don't do complex congenital and the case mix is tight. So QE would probably be the best place in the Midlands, and they normally have a post-CCT imaging fellowship at the QE. Otherwise, in the Northwest, Liverpool Royal would be good. That's where I did my CT fellowship. They have a very good cross-sectional cardiac imager there. So with cardiac CT and CMR, I think in the UK, those would be the big centres. But remember, with fellowships, even if there isn't a fellowship advertised for imaging, you can make your own fellowships. You can contact people a year or 2 before and say, look, I'd like to do a fellowship with you. Is that a possibility? And they'll often make a fellowship for someone who's keen and good, because they'll appreciate a very, very senior trainee coming to them. So the famous centres are the Brompton probably, and the London ones, but there's lots of good centres around the country. And like with intervention, you get these BSIS fellowships and things advertised. You may not get them for imaging, but it doesn't mean they don't exist. You often end up with imaging making your own fellowship by contacting people in centres where you'd like to work a year or 2 in advance. That's what I had. That's what I did for mine. I specifically wanted level 3 CT, and I knew I could only get it at 1 or 2 places in the country where I'd get the volume, the case mix. And to get level 3, you have to be under a level 3 trainer, and you have to teach on 2 level 2 courses. So that's why I went with Liverpool for that. So you have to be selective in that way. But there was no such thing as a fellowship advertised. I contacted them and built it myself.
Dr. Jamal, can I ask one final question? Apologies, I know we are running late, but thank you very much for this excellent talk. Honestly, we really learned a lot, and you're a fountain of knowledge. One question from a person who doesn't want to be named.
Honestly.
Yeah. So a friend of mine who doesn't want to be named is asking that if AI is the future, how do you see the future of imaging consultants?
A very, very strong future, a very, very bright future. Remember, contouring the ventricle and drawing contours is not all that we do in MRI. The future with AI will be a much more efficient, slicker, better future, because we will save time on the mundane aspects of CMR, which is contouring and drawing things, because the machine will do that. That's only a fraction of it. You know, a machine can calculate an LV and RV volumes and ejection fraction. That means nothing. It'll give you an accurate number. The report itself is a combination of looking at the findings, interpreting it in light with the question, interpreting it in light with the clinical picture, and then putting everything together. AI will just give you numerical values. It's what you do with those numerical values and how you interpret them which is what the report is. So, you know, the AI will never threaten the imager. Don't worry, guys. Don't be threatened by the machine. The machine will be your friend and just do the boring jobs for you that you get bored after you've done maybe 1,000 MRIs and you don't want to contour anymore. So it will just do the boring, repetitive numerical tasks, but you'll still be the one interpreting the scan, putting everything together. And you'll probably be able to speed up the number of scans you do per list. You'll be able to do more patients and more throughput, and really concentrate on the important aspects of imaging. So don't be threatened by AI. It will be your friend. It will never replace us, ever.
Thanks,
Thank
Jamal.
you.
And Rahil, on that question, if Jamal, if you allow me to add something on a lighter note, the I in artificial intelligence, the intelligence comes from the imaging consultant. So no matter how artificial the setup, you need an intelligent interpreter.
It's like
Right.
that with anything. It will always be our friend, and we'll welcome it. I think it's exciting. I think it's really good. We shouldn't be threatened by it. AI will come into everything, not just imaging.
Jamal, thank you so much. We really appreciate your time. Thank you, Rahil and Essen, for excellent moderation and hosting. If there's no other comment to add, I'm going to stop recording now, which I have done